This conference will now be recorded.
Hello? Hello? Hello, everybody? How are you? Welcome. Is my voice is clear?
Clear, ma'am.
Yeah, fine. How are you and how's your studying, all of you? I hope everything is fine. I know this time is very, you need any single minute to do what you want to do. Really, really, it is very critical time, okay? So, inshallah, today we will discuss the remaining of the Gynae Oncology, okay? And after that, we will, just for maybe 1 hour and a half, because I don't want to waste your time, okay? Because I know that you have a lot of things to be read this time, okay? Actually, because I received a lot of requests to do this, the remaining of this lecture. That's why I did this, really, because really I know that you don't have a time right now, because almost maybe 4 or 5 days remaining. Am I right? Yeah. So we'll go quickly, okay? Try to if my voice is not clear, tell me. No questions. Better if you have any question, just test me in the Telegram group, okay? Because no time really. Okay, and I want it to be interactive session. I want all of you to participate, okay? But without delaying the session, okay? Okay. Again, thank you for all who help in this crash course, all of them, our mentors. Really, they did a wonderful, great job. Okay, this is our group, me and Dr. Abtihal, as we know, MRCOG Secrets Group. Okay, this is the Gynae module. And you know, when things get hard, I know this is a hard time now, and you need to not to waste time. Just go for prioritize your things, okay? This is your situation right now. Am I right? You want to revise everything in each you see how many places, all these you need to now this time to remind all this and to revise all this. Isn't it?
Yes, ma'am.
Yes,
Yeah.
ma'am.
Yeah, exam is stress. Just we have a tips before the night before your exam. The first thing is that you should spend some time visualizing a positive exam experience. You see people who passed, they are not better than you, okay? And it is possible if it is be done by anything else. So means that it is possible to you to have this great achievement, okay? And this inshallah will increase your confidence and help you with nerves and enhance your mood, okay? Take your best performance, think about your previous good performance and see if you enter this exam before, why I didn't pass in this exam. Put your mistakes, okay? And see it, what's the problem, okay? And also your preparation, remind yourself, okay? And how much your revision you have done. Try to revise every single idea or any single things, okay? Because really you need this. And as I told you before the exam, all this, it can enter your brain, okay? But try to not to try to sleep early, okay? Not to studying till 1 p.m. or 1 a.m. or 3 a.m. No, this is not the time, okay? And focus on you, focus on yourself, and don't compare yourself to others at this time, especially because this will give you feel stressed, okay? Always focus on what you can control, okay? The challenge, this is a big challenge actually, and it's great challenge. And if you did, this will be a very big achievement, really, and you will be proud of this, okay? If you see the exam as a threat, it will make you stressed. View the exam as an opportunity or as a challenge. This will make you feel better, okay? Overcoming setback, remind yourself how you overcome previous setbacks. This will help you deal with future challenges and build mental resilience, okay? The last point is that a good night's sleep. This is very, very important. At least for 10 days before the exam, don't try to not to try to sleep early, okay? يعني it is enough after 9 يعني 10 11 it is enough, okay? So a good night's sleep helps improve creativity, problem solving, concentration, and memory. Do you know? This is more important than last minute cramming, okay? And don't try to have to get a new idea or new things. No, just revise what you read, okay? This is very important. And try to catch it, even if you have, for example, something you don't know it, you can from your friend to catch it from your friend, okay? Okay, so I think let's to start with our EMQ and SBA, okay? The last one, because we didn't complete it, okay? Who will take the first one? Let's go fast.
I can
Hello.
try, ma'am. I can try, ma'am.
Yeah, please try. This is the question.
53-year-old woman presents with severe uritis and thinning of the vulval skin, which bleeds on scratching. There is pain, discomfort, and dyspareunia, and adhesion of the labial margins on examination. She also suffers from diabetes. Okay, can I
so
see
this is the question. Yes, this is the question. Sorry.
Let me see. So most appropriate management we have to give. Okay.
Yeah. Just let me, Doctora. Just I want to answer my mom. Just 1 minute. Hello. Hello.
Yes, ma'am.
Yes. Is my voice
Yeah.
is clear now? Yeah.
Yes, ma'am. Yes. Ma'am, I think it should be clobetasol. Is this lichen sclerosis?
Yeah. Lichen sclerosis. Yeah. Exactly. Okay.
A 33-year-old woman presents with recent onset of irritation and soreness of the vulva, but with a long-standing history of vaginal discharge. There is also evidence of an inflamed area on the inside of the thigh. Okay, long-standing discharge, but recent soreness and irritation, inflamed area on the inside of the thigh.
Yeah.
Okay, ma'am, can I see the options?
So yeah, I will. Yeah. Sorry.
No problem, ma'am.
Yeah.
I don't know what this condition is, but
Mhm.
something on the inside of the thigh.
Yeah. So what is
Yeah.
your most appropriate management? So read the question carefully. What he want? He wants the appropriate management for this patient. Okay? This is very
Okay.
important. Yeah. Again, we'll
Mm,
read scenario. Okay? Yeah. So the patient is
recent
33
onset
years old. Mhm.
recent onset irritation and soreness is there, but a long-standing history of discharge is there. And now there is
Yeah.
an inflamed area on the inner side of the thigh.
Yeah.
So it
So you will start by what? You will start by the general measure
general
first.
measures, general
Yeah.
measure.
Yeah,
Okay.
exactly. So you see, just go simple. Go simple. Okay. So the most
Okay.
important one is that you will start by the general measure, the first thing. Okay.
What exactly is the thing they're talking about, ma'am? What condition is this?
This
Nothing
most likely is
specific.
Laschen simplex. Laschen
Okay.
simplex.
Simplex.
Yeah.
Okay. Okay.
Always when you see that there is, for example, inflamed area in the inner side of the thigh, most likely it will be due to Laschen simplex. Okay. As we said before in the last session. Okay.
Okay, ma'am. Okay.
Yeah. So this is the answer. The first one is the clobetasol, excellent, and the second one is the general measure. Okay.
Okay, ma'am.
Yeah. Alhamdulillah. So
42
you
year.
will go for the
Okay.
other.
Okay, one more I'll go, ma'am. 42-year-old women presented with recurrent oral and genital ulcers, which are quite painful.
Mm-hmm.
There is extensive evidence of scarring from previous lesions.
Mm-hmm.
So I think this is that orogenital vulval syndrome, orovulvovaginal syndrome. I think it is talking about. Um,
It is
it's
what?
in. It's
So mhm.
yeah. I'm thinking it's. I think
let's
lichen
let's see
planus.
the
Yeah.
the option.
One
This is the
second.
option. Yeah.
Okay, it again wants me to give this only.
Yeah.
Still clobetasol, ma'am? I don't know. Oh, not really sure.
This present with what? Recurrent oral and genital ulcer and quite
Hmm.
painful. There is extensive evidence of scarring from previous lesion. What is it's most likely what it will be?
It's that orovulvovaginal syndrome, ma'am. I think, is it lichen planus? I'm not really
Lichen
sure.
planus.
It is most likely oral recurrent oral ulcer and genital most likely it will be Behçet disease.
Oh,
Am I
Behçet's
right?
disease. Then
Yeah.
steroids and immunomodulators will be required.
Immunomodulator. Yeah. So this is like remind you, okay, reminder for you. Recurrent oral and genital ulcer, this is most likely it will go with the Behçet disease. Okay? This is most likely, and it is quite painful. Don't forget. It is painful, quite painful. Okay?
Okay.
Yeah.
Thank you, ma'am.
Yeah. Excellent. Next, who will go for the next? Yes, yalla. I will need you to go fast because no time, dears.
Okay, ma'am, I'll read this.
Mhm.
A significant pruritus in a 52-year-old smoker with 56 red plaques and some warty lesions.
Mhm.
Red
Pruritis,
plaques. Red.
52, smoker, warty lesion.
Okay, ma'am. Can I
We'll
see
go
the
for the
options?
question. Yeah. Mhm.
Hmm. Red lesions go with lichen planus. She's 50 years old, so
It is 52 years old and
yeah,
smoker.
56.
Smoker.
So should we take an excision and then find out what it is
Yeah,
really, and then
exactly. This most likely it will
yeah,
be VIN. Most
F,
likely
local
VIN. So
excision.
yeah, we will go for local excision. Okay? Most likely. Okay?
Of
So this is the answer for the previous one, immunomodulator, and your answer is local excision, because this is a classic example of the type, the usual type of VIN with warty plaque-like lesion. Okay. In this case,
Yes,
most
ma'am.
likely the patient is a smoker, one of the risk factor. Okay. And because it may be human papillomavirus infection or whatever. Okay. And her age, all these things go with low immunity. So most likely it will be this patient, local excision is the best one, because most likely it will be VIN. Okay. So that to diagnose. Yes, this one.
A 32-year-old woman presents with vulval lesions that are smooth and discrete, red in color but not affecting the vaginal mucosa. The patient also complains of discrete lesions in the flexural areas of the thigh. 30-year-old.
So what you will give her? Smooth, discrete, red in color, but not affecting vaginal mucosa. Means that it is Lichen sclerosis. Am I right? So what is the treatment of lichen sclerosis? You will go for?
Clobetasol.
Yeah, exactly. And if
Clobetasol.
just when you read the question,
Ma'am, but
try
age, ma'am, lichen sclerosis peaks in prepubertal and postmenopausal. So 32 years, I was just
but it can
contemplating that.
Yeah, it can be even in
Okay.
in young. Yeah, even in young one. Yeah, it can be. Okay. So just try to see what is the diagnosis first,
Okay.
and then go for the So the next question. Yes.
44-year-old woman complains of a long-standing history of inflammatory bowel disease and complains of recent onset swelling and ulceration of the vulva and occasionally something draining out of these swollen areas. 44 years.
Yeah.
IBD
Longest
and
standing history of inflammatory bowel.
Can I see the options, ma'am?
Okay. Yes. So this most likely this patient
should we go for immunosuppressants? Crohn's disease of the vulva.
So
Immunosuppressants she might require.
Immunosuppression or immunomodulator?
Immunosuppressant therapy. Okay, immunomodulators.
Yeah, the answer is immunomodulator. Okay, this is most likely a case of inflammatory Crohn's disease. Okay, and it is extensive, reaching the vulva. Okay, that's the scenario for this one.
Okay.
Most likely it will go for immunomodulator, the treatment, because the question is asking about treatment. So very important to see what the question need from you, what you want from you. Okay. Yeah. Next.
Okay. 70-year-old is diagnosed with vulval cancer. She gives history of lichen sclerosis. What percentage of vulval cancer is associated with lichen sclerosis? 30%.
30%. So the answer is
A, ma'am. Yeah. A.
Yeah, it is actually, we found it, I think, in one of the talk, I think 30%. But here he said that it's 33% as per the, I mean in the Strat OG, and even in one book, it is 30%. But in the talk 2010, it is 33%. Okay? So this answer is D.
Okay.
Okay? Talk 2010.
Okay.
Yeah. Next.
70-year-old is diagnosed with vulval cancer. She had wide local excision and lymphadenectomy for staging. The following lymph node excision has the lowest morbidity. Radical lymphadenectomy, sentinel node biopsy, systemic. Lowest morbidity will be sentinel node biopsy.
Yeah, exactly. Excellent. Thank you, my dear.
Thank you, ma'am.
Yeah, thank you. I hope you all the best, inshallah. You'll do well, inshallah. All of you.
Thank you.
Yes,
Thank you,
next.
ma'am.
Thank you, my
Dr.
dear.
Rasha, just the previous question, can you just put it? I want to take a screenshot of answer for that.
I will send, my dears. I will send today the PDF. Don't worry. I will send today. Okay.
Can I share, Dr. Rasha?
But if you want to take just to help you, but already I will send it today, my dear. This one, okay? Take it. Okay, you take it?
Yes, yes.
Shall I do one?
Yeah. Who want to do the next question?
Yes.
Ma'am,
Khalid.
myself.
Can I go?
Yes.
Can I go, please? Yes. There is.
Dr. Rasha, I have a question to you.
Please, يعني I want any question. Just this one. If I saw that it is really important, I will send it in the group. If it is like just something to explain it, I will explain for you. But just text me in the Telegram, okay? Because really no time. I know most people said to me no time, okay?
No, it wasn't. It was regarding a question that you just now posted. That's the question I wanted to ask. The question about a lesion which was scaly, which was red, which was involving the flexures. Well, can't we even think of psoriasis in that? Should we think of lichen sclerosis? The one you said, lichen sclerosis.
Which one, my dear?
I think it could be 19 or 18. 18 or 19.
Which question number? Which number? This one?
Yeah, this one, because it's red in color. Yeah, red in color, involving the flexural areas of the body. In case it comes like this scenario comes, can't we even think of psoriasis, vulva?
Because they're not affecting the vaginal mucosa, no, ma'am. So can be psoriasis.
It can be, but he's asking in this question. He's asking about the general measure. Am I right? Most likely.
Yeah, he's asking for the treatment, but the diagnosis can be psoriasis, right?
Yeah, it can be. Yeah, you're right.
Okay, thank you very much. Thank you. That's all. Thank you.
Yeah, thank you. Which question now? Just 1 minute.
Can I go?
Yeah.
Yeah, this is
Khalid.
So,
yeah. How are you, Dr. Khalid? Hope, inshallah, you will clear this exam, inshallah, soon.
I hope.
Yes.
I hope. Thank you very much.
You're welcome. So,
the risk of contralateral. Yeah. Shall I go, please?
Yeah.
The risk of contralateral lymph node involvement in the laterally placed lesion of vulval carcinoma is laterally vulval. It's less than 1%.
Yeah, excellent. Yeah, exactly. Less than 1%. Okay. Next question. What is this? Sorry. This is actually, you are lucky, Dr. Khalid. The answer came before that.
I hope I will be lucky as well later on.
Okay. So let's okay. So let's start.
Yes. Presented to you in the gynecological outpatient clinic with vulval soreness and itching. On examination, you find suspicious of vulval lesions, and you take a biopsy. 2 weeks later, you review her, and the histology report show irregular sawtoothed acanthosis, increased granular layers and basal cell lichenification and band-like dermal infiltrate that mainly lymphocytes. So from the two
the key in this word, the key, what is it?
Many keys. The first one is sawtoothed and acanthosis. All of this go with lesion planus, I think.
And also what?
Lesion planus and
This lymphatic, isn't it?
yeah.
Yeah. So lymphatic, and the patient have this acanthosis most likely go with the autoimmune. Okay. All these things, and soreness, itching, all these go with lesion planus. Okay. Most likely the answer is lesion planus. Okay. I think this is the erosive type of the vulvar subtulfine reticular plaque to severe erosive disease. This is most likely this condition. Okay.
Sorry, and what is the other condition which also associated with lymph?
Yeah. He just here asking just about what is it what the type?
Okay.
Yeah, but you should know at least maybe it come to you at the type.
Yeah.
But most likely the exam don't go deep. Go for the biggest things. Okay. Yeah.
Okay. What percentage of patient in the dedicated vulval cancers present with lesion sclerosis?
Yes.
Lesion sclerosis. Percentage.
This is actually recall question.
Is it 10%?
It is. It is 1/4.
I'm not sure.
25%.
1%, 25%.
Yeah. 1/5. I mean 1/5. Yeah. Okay. This is. Okay.
Yeah, thank you.
With EMQ. Mm-hmm.
32 years old woman presented with extensive ulcer on the vulva and dirty brown vaginal discharge of 7 months duration. The discharge is intermittent. The ulceration are widespread and are associated with significant scarring.
Yes. So, if we summarize the case, 32 years old, present with extensive ulcer on the vulva and dirty brown vaginal discharge for 7 months duration. Okay, the discharge is intermittent. The ulceration are widespread. Okay, with significant scarring. So, most likely it will be in your mind. What is it? This one. Extensive scarring.
Extensive scarring?
Yeah. Ulceration all over the body, as he said here. Most likely it will be. Because most likely the vulval ulcer associated with the scarring, most likely to be associated with Crohn's disease.
Crohn's disease.
The difference between yeah. So most likely it will be vulval Crohn's disease. Okay.
N. Then the answer will be
yeah.
N, yes.
N. The answer is N. Yeah, exactly. I know it is a little bit difficult, EMQ. Sorry, but exam it will be easier than this, inshallah. Okay.
Inshallah.
Yes.
Yeah. Yes, I want you to concentrate يعني how the question can come. Okay, question 27.
43 years old, present with troublesome itching of the vulva for 12 months duration. She was sterilized 7 years ago and her last cervical smear was 2 years ago. On examination, her vulva is found to have multiple red clustered plaque with sharp edge.
Yes.
No other pelvic abnormality is identified. 43 and sharp edge. Can I see the options?
Multiple crusted plaque. طيب.
Multiple crusted. Sharp edge.
This is a difficult question actually. A little bit difficult, this question, really.
Sharp edge, we find sharp edge on healed.
This is
I will go for
43 itching, 12 months. Budget disease. Yeah, excellent, excellent, Dr. Khalid. You are right. It is budget disease. Excellent, excellent, wallahi, mashallah. So this is the answer. Okay, we will see now. The first one is, as we said, that it is vulval ulcer associated with scarring are highly indicative of Crohn's disease. That's the second one is that this is the characteristic of diagnosis of vulval budget disease. So this question, try to memorize well, revise it well, because this is the characteristic of budget disease. And also, if you found with it in the question, the other key in the question, if you go, for example, in the question here, he said that she's 43 years old, troublesome of the vulva of 12 months, sterilized 7 years ago, last smear was 2 years ago, her vulva have multiple red crusted plaque, sharp edge. Okay, no bulbic abnormality is identified. But if you have another key, it is really difficult. But just revise this one: multiple red crusted plaque with sharp edge. Other thing is the adenocarcinoma. If you found that there is adenocarcinoma of the breast or whatever,
but it excludes the carcinoma by she's having regular smearing.
Yeah.
Can I see, please, the options?
Exactly. Because he want to mislead you.
Yeah.
Okay. Yeah. Next question. Sorry. It is a question.
Yeah, 51 years old patient come to see you due to vulval pruritus that she is extended to the mons pubis and inner thigh. On examination, there is erythema to the area of the pruritus with some thickened leathery area of skin and overlying scale. The erythema is going with eczema.
And what else? Yes.
And
so eczema is not here. So the second one.
Her age is 51.
Yeah. Most likely the eczema it will be with two things, either the simplex, Lichen simplex, or the eczema. So most likely here it will be with Lichen simplex. Okay. So erythema, يعني put in your mind it will be with these two things. Okay.
Yeah. Yes.
Yeah.
Okay. Excuse me, can't this be psoriasis?
Psoriasis should be systemically, I think.
Yeah, exactly.
Because of the scale.
It can be, but it is most likely go with the simplex, the erythema by itself. Most likely go with simplex and the, which we said now, the eczema.
Eczema, yes.
Yeah. So this is Lichen simplex, chronic. Yeah, you are welcome. Chronic vulval dermatitis, eczema, there is generalized skin irritation. Okay, with pruritus, the dominant feature. The chronic skin inflammation can result in thickened, leathery, sometimes hyperpigmented skin with scale. Okay, this is because of the scale here. This is because of the inflammation. Okay. Thank you, Dr. Khalid. Excellent.
You're welcome. Thank you very much.
Thank you. Hope you all the best, inshallah, in your exam.
Yeah,
Who will go?
You, my sister.
Thank you. Anyone?
Ma'am, shall I do, ma'am?
Yeah, please fast, my dear, because we want to finish.
Okay, ma'am. A 5-year-old girl presents with burning and maturation and vulval scratching. On examination, the vulva is noted to have well demarcated white area around the introitus. The overlying skin appears thin with extensive fissuring. The perianal area is not involved. Ma'am, probably it is lichen sclerosis, ma'am.
Yeah, lichen sclerosis. Excellent. The second one.
70-year-old postmenopausal woman presents with vulval itching. She has a narrow introitus. The skin over the labia, perineal area, and the genitocrural folds is thin, dry with white discoloration, superficial excoriations. Biopsy shows atrophic epidermis with hyperkeratosis and superficial dermal hyalinization and lymphocytic infiltrates. Ma'am, this is also lichen sclerosis, ma'am.
This is 70 years old. Okay, she had
Yes, ma'am.
yeah, burning sensation. She had erythema with marked edema and numerous small superficial ulceration. Okay,
it is
and
dry white. Dry and white in color.
I'm reading. Yeah.
Okay.
So, yeah, both of them are lichen sclerosis. You are right. Yeah. Sorry. Yes. You are right. This one also, it is lichen sclerosis. Okay, because here even hyperkeratosis, lymphocytic infiltration, all these things, it is always goes with this. Okay.
Yes, ma'am.
Next, who will go for the next? Yeah, thank you, my dear.
Okay, ma'am.
Can I try?
Yeah.
Dr. Okay.
Yeah, Dr. Asma, yes.
A 23-year-old woman presents with vulval itching. On examination, there is a well-demarcated symmetrical lesions involving labia majora and minora extending into the genitocrural folds. The lesions appear beefy red with scaling. The biopsy shows papillomatosis, parakeratosis, neutrophils, and leukocytosis.
Exocytosis. This is what? This is papillomatosis and parakeratosis. This is characteristic of what?
Parakeratosis. Getting it.
It's affect, but it is away from the vaginal mucosa. If you read it, yeah. So it is vulval itching, well demarcated.
Vulval candidiasis. VVC.
What?
Vulvovaginal candidiasis.
No, it's not. This is characteristic for what? Characteristic for psoriasis. This one. The papillomatosis and parakeratosis. This is in the histology. Most likely, it will be characteristic for the psoriasis. Okay.
Yeah.
With scaling also. Yeah. So this question, try to memorize these words, because these words will let you to know about the case. Okay. So it is vulval itching, vulval labia majora and minora extend to the this fold, but without going to the vaginal mucosa. Okay. Beefy red. This one. This is also characteristic of the psoriasis. Beefy red. Okay. Scaling and papillomatosis, and just this is typically psoriasis.
But usually vulval psoriasis does not have scaling, no?
Sometimes it can, because it will be inflammation of the skin.
Right.
The scaling is because of the inflammation. Okay. The next question. Yes.
34-year-old woman presents with burning sensation in the vulval region. On examination, vulva is edematous with marked edema, numerous small superficial lacerations. Inguinal lymph nodes are enlarged and tender. This is herpes. Herpes simplex.
Yeah, herpes simplex, exactly. Excellent. Yes. Yeah, exactly. It is herpes simplex. Okay.
Can I
go
continue?
with this? Yeah.
27-year-old Egyptian nulliparous woman has recently married and complaining of new onset vulval pain. She describes pain with a slight touch, particularly on intercourse when using tampons, and she localized it around the vulva. So this is provoked localized vulvodynia, that is vestibulodynia. The pain is not present at the time of it's not, I can't read this. She does not report any itching, soreness, or unusual discharge. What is the most likely diagnosis? It is vestibulodynia, C.
The answer is C?
Yes.
Yeah, exactly. Yeah, excellent. The next question.
70-year-old woman presents in the gynecology clinic complaining of vulval pruritus. On examination, the vulva has lesions which are sharp, bordered with red and velvety texture and islands of hyperkeratosis. Biopsy was done and histology shows a large, round, atypical cell with oval nuclei and pale cytoplasm within clusters among the cells of the epidermis. Diagnosis. This is Paget's disease of vulva.
Paget's disease of the vulva. Excellent. Yes, exactly. Yes. Answer is D. Yeah.
We are about to see a 60-year-old woman at the vulval clinic. She initially presented 2 weeks ago and complaining of soreness and irritation of the vulva. On examination, there was a 4.5 centimeter ulcerated lesion on the left anterior vulva involving the clitoris. Biopsy was taken and histology reveals a squamous cell carcinoma. In addition to a radical excision of the primary lesion, how will you go to counsel regarding lymph node management? So it is a 4.5 centimeter lesion on the left anterior vulva involving the clitoris. So lymph nodes will be bilateral dissection.
So what is the answer?
Bilateral in inguinofemoral lymphatic.
Yeah, exactly. Yeah, exactly. Excellent. Yeah. Bilateral, yes. Okay, this is just tips for the vulval lesion. I write it, okay, so that you can just make a. I will send the PDF. Just you will know it. Yani it is simple things. Just in the exam, help you in finding the keyword in the question. Okay.
Yes,
all these things about basit, about vulval, about Lashin simplex, all these things. Inshallah, I will send for you the. Okay. Okay. Inshallah, all of you will reach, inshallah, this success, inshallah. Okay, so let's start with the cervical cancer, FIGO 2000. Just a minute. 2018, okay, and don't stop trying, inshallah. Success is very near, inshallah, bi'idhnillah. Okay, so before we will start the cervical cancer, can you tell me about the cervical cancer? Is it increase or decrease? Anyone can tell me, is it increase or decrease in UK?
Decreasing. It is decreasing.
It's decreasing. And why? Because of what?
Because of HPV screening and HPV vaccination.
Yeah, so the HPV or the cervical screening program, it decreased the cervical cancer by how much? The percentage I need?
70%.
70%. And what about the it decreased? This is for the cervical cancer, the national cervical screening. Am I right? Okay. And what about the vaccination? It decreased the cancer by how much?
50%.
90%.
Yeah. 52% most likely in the strategy. Okay, this is very important question in the exam. It can come to you. Okay, so regarding the this one about the cancer research center in UK, okay, up to date now, what is the most common female malignancy? Okay, for the female, I mean, anyone can tell me?
Breast cancer.
The first one.
Breast
Cancer.
cancer.
The first one is breast cancer. And what about the second?
Lung
Endometrial.
cancer.
Second is cervical.
No,
Lung.
endometrial.
Endometrium.
Second, I mean for the female. I'm asking about female, not gynae.
Second is
Gynae.
cervical.
Lung cancer.
Endometrium.
So this is actually exam question. Yeah. The
Lung
first one is
cancer.
the breast cancer. The second one is bronchogenic cancer. Am I right?
Yes, ma'am.
Lung cancer.
Yes.
It is.
Lung cancer, yeah. And the third one?
GIT cancer.
Endometrium.
Colon.
The bowel
Third is
cancer.
colon.
The bowel cancer. Yeah.
Bowel cancer.
And the fourth one?
Endometrial cancer.
Endometrial cancer.
Uterine
Yeah.
cancer.
Yeah. And what about the fifth one?
Ovarian.
Malignant melanoma. The last one is the ovarian cancer. Okay? So breast, lung cancer, bowel, endometrial cancer, malignant melanoma, and ovarian cancer. This is as per the up to date. Okay? What about cervical cancer
Can
in
you
UK?
repeat, please? Dr. Rasha, can you repeat, please? Breast, lung? Is it lung?
Breast,
first or
lung,
breast?
bowel, endometrial cancer, malignant melanoma, and ovarian cancer. Okay?
Dr.
Okay.
Rasha, can I tell something, Dr. Rasha?
Yeah.
The most common cancer that I read was lung first.
Yeah, that's what
Next,
we feel also.
yeah, lung is the first, and then comes the breast.
Breast. Second is breast.
Second is
That's
the
what
breast.
I read. I read like
What we solve in the question, in our question? What we solve? Lung or
Okay.
breast?
Lung for both male and
I
female.
joined a little late. I don't know.
Yeah, as I understand. But in the female, now I'm talking about female. Okay?
Yes, yes,
Even
About
female
female.
lung.
The first is
yes.
breast
Lung.
cancer.
Okay, okay,
Okay?
whatever.
The second
Yeah.
thing about
to cause death.
about the gynae cancer in UK. The first one is
Lungs.
Endometrial.
the first one is the
Among the
endometrial
gynae
cancer.
cancer,
Excellent.
first is endometrial.
And the second?
Ovarian.
Cervical.
The second is the ovarian cancer. And the last one, the third one is the cervical cancer. Okay?
Yes, yes, I agree.
Yeah.
I agree. The first one is endometrial.
Sequence, please. Just
Sorry?
repeat them in both female and gynae cancers. Can you repeat them in a sequence, please?
Yes. Okay. So as we said, the first one is that the endometrial cancer. The second one is ovarian cancer, and the last one is the cervical cancer. This, if you go for a gynae cancer in woman in UK. Okay. It is like this. Regarding the other question, you will find it in our the recall group. Okay, about the February 2020 question. Okay, you will find other question regarding this for the recall. Okay, so just let now to start. What is the major risk factor for this cervical cancer? I ask you this question because this is, you should know what is the gynecological cancer, what is the first cancer in the female. This is very important. Okay. What I want to tell you also about the major risk factor for the cervical cancer is that the early onset of sexual activity. This is one of the risk factors. Multiple sexual partner. Okay. The other factor is if there is coexistence, for example, like low socioeconomic class and cigarette smoking, oral contraceptive pill, sexual transmitted infection, and also particularly human papillomavirus and immunocompromised state, including HIV. All these are risk factors for the cervical cancer. Okay? Human papillomavirus is found in over 95% of cervical cancer, and this is exam question. Okay? So human papillomavirus is found in over 95% of cervical cancer. In the UK, the most common subtype found in cervical cancer are human papillomavirus 16 and human papillomavirus 18, as well as 30, 31, 33, and 35. Is it clear till now?
Yes, ma'am.
Hello?
Yes, ma'am.
Yeah.
Yes, ma'am.
Sorry. Yeah. About human papillomavirus vaccination. This is very important, and I put for you here the new one for the, because nowadays they start this human papillomavirus vaccination for even for the boys. Okay, so the primary prevention of most cervical cancer is now with the licensing of the first one. Okay, with the license is now with the licensing of the first vaccine in 2007. Okay, and human papillomavirus causes cancer and other serious disease in both sexes. And girls in the UK have been vaccinated since 2008. Very important, this area. The starting of the vaccination is in 2008. Regarding the boys, it started in September 2019. If he asks you, you should know that human papillomavirus vaccination for boys nowadays started in UK in September 2019. Very important information, this one. Okay?
Ma'am, it's 2 doses, 1 month apart, ma'am. 2 doses will be given.
I will come, my dear. Just wait. I will come. I will discuss this. Okay? In the same. So vaccination for boys started in September 2019. Now just fix on this point. Very important, this point. The two most common high-risk human papillomaviruses for development of cervical cancer are 16 and 18, and approximately 70%, okay, of squamous cell cancer. A bivalent human papillomavirus 16 and 18 vaccine, which is Cervarix, has been shown to be highly effective in preventing high-grade CIN and has been adopted for use in the UK vaccination program. A second quadrivalent, which is Gardasil, and this is very important also, and it comes in the exam. It is quadrivalent, means that for including human papilloma virus type 6 and 11. Okay, appears equally effective in preventing development of high-grade CIN, as well as reducing the incidence of genital warts, which are due to these later two human papillomavirus subtypes. Okay, very important. So nowadays, adopted for the Cervarix and started a second quadrivalent vaccine, which is the Gardasil. Okay. Since September 2012, the vaccination program have used Gardasil. This is area of exam question. They're asking about the Gardasil. It started from 2012. Okay. Is it clear?
Yes, ma'am.
Yes, ma'am.
Yeah. So what about the time? Anyone can tell me? The one who asking about the vaccination.
I just know that 2 doses, yeah, 2 doses are given at age of 12 and 13. But I'm not sure of the gap between the 2 doses.
No, there are total three doses. 3 doses total and given for now. One in the first month, second in the second month, and third that is after 6 months.
Yeah,
no,
exactly.
No, that is the ma'am, for the
It's the old
school goers, it's 2 doses, no? School goers, like you, a universal immunization program, it's 2 doses for the adolescent boys and girls.
Less than 13 at 0 and 5 months. More than 13 at 0 and 1 month and 5 months, I think. 3 doses for more than 13, according to the age.
It is 3 doses. 3 doses at 0, 2, and 6 months.
0, 2, and 6 years. Three doses.
0, 2, and 6 months. Okay.
Adolescent 2 doses, ma'am.
Yeah, adolescent just 2 doses. Okay. Okay. So for the clinical symptoms here, postcoital this is the clinical symptom. So it means that if the patient came to you and later on you diagnose her with cancer, most likely the patient will have postcoital or interministerial bleeding. Most likely she will have persistent vaginal discharge, which may be blood stained, postmenopausal bleeding. Okay, and speculum examination may reveal an obvious cervical tumor. And at this time, in this situation, you should take a biopsy to confirm the diagnosis. Okay, with large necrotic tumor, the central area may not have any viable tumor, and ideally biopsy should be taken from the edge of the tumor. Very important. Okay. Once the diagnosis is confirmed, staging will be undertaken to assess the spread of the disease and plan treatment. Okay. This is the staging. Anyone who want to talk about the staging? This to be revised for him.
Yes, ma'am. This is the FIGO staging 2018. The stage 1 is when it is the cancer is strictly confined to the cervix. It is divided into 1A and 1B. 1A is when it is the depth of invasion is less than 5 mm. Now in that 5 mm, less than 5 mm also, it is divided again into 1A1 and 1A2. 1A1 is less than 3 mm and 1A2 is between 3 mm to 5 mm.
Yeah. Yeah.
Then 1B. 1B, the invasion has gone more than 5 mm, but the lesion has to be still, since it is still in stage 1, so it has to be restricted to the cervix. In that it is now, earlier it was only 2 stages, now it is 3 subdivisions, B1, B2, B3. The B1 is from more than 5 mm, to less than 2 centimeters. Then from B2 is 2 to 4 centimeters and B3 is more than equal to 4 centimeters. Then we come to stage 2. The stage 2 is when it has gone beyond the cervix. That is, it has invaded beyond the uterus actually, and but it has not extended into the lower third of the vagina or not involved the lateral pelvic wall. So in 2 there are 2A and 2B. In 2A it involves the upper third of the vagina without parametrial involvement. That again is divided into A1, A2 according to the size. That is, if the lesion is less than 4 centimeter and involving the upper 2/3 of the vagina, it is A1, and if it is more than equal to 4 centimeters, it is A2. Then 2B is with parametrial involvement, but it should not go up to the lateral pelvic wall. If the lateral pelvic wall is involved, it becomes stage 3. Then stage 3 is either lower third of the vagina or extension to the pelvic wall, or the clue could be hydronephrotic kidney with or without involvement of the lymph nodes. That is divided into further 3A, 3B, 3C. 3A is when it has gone to the lower third of the vagina. 3B is when it has extended to the pelvic side wall, and in this stage only there will be hydronephrosis and non-functioning kidney. And 3C is when there is involvement of lymph node irrespective of the tumor size or the extent. And there could be notations like R or P. If we find on radiology, we write R. If we find on pathology, we write P. And there is C1, C2. That is pelvic lymph node only is C1, and para-aortic lymph nodes plus minus pelvic lymph nodes is C2. Then stage 4 is distant spread, that is outside the true pelvis, in which there is 4A, which is spread to the adjacent pelvic, it's beyond the true pelvis actually. And 4A is the adjacent pelvic organs and 4B is the distant organs.
Yeah, exactly. Okay. So just I make this just to help you.
Dr. Rasha, you can tell us in simple way?
Yeah, I will tell now. Okay. Just let me finish. Okay. So here's a classification of the FIGO classification of the carcinoma of the cervix. Okay, it is divided. Most likely, I bring this picture because it will be easy for you. Okay, so in the stage 1, you see it is most likely just for the cervix, confined for the cervix. Okay, not go beyond the cervix. Okay, so not go for example, the corpus or whatever. So just it is in the cervix. Okay. So in 1A, it is 1A means that it is invasive, that can be diagnosed only by microscopy. So 1A, it is just by microscopy, okay, with a maximum depth of less than 5 millimeter. Means that inside, the depth is inside, okay. For the 1A1, for the 1A1, it is measured stromal invasion less than 3 millimeter. Okay, this is the stromal invasion, means that the stroma يعني inside. Okay, for the it is less than or equal to 7 millimeter if we take it as for the depth. Okay, so it is stromal invasion less than 3, and regarding the depth, it will be less than or equal to 7 millimeter. For the
Ma'am, this is the old one, ma'am. This is the old one.
I think this is the old one, صح? Yeah, this I think
Yes,
this
Because
is yeah.
old one, yeah.
So I don't want you. To go for just 1 minute. Yeah. Yes, I want to symbolize for you. Okay, just go for the. Okay, so it is very simply. It is for the cervix, means that it is in the cervix, not go beyond the cervix. Okay, it is just it is confined to the cervix. Extension to the uterus corpus should be this grade, means that it's not included in this stage, because even in stage 1A it is just microscopically. Okay, so 1A1 it is major invasion less than 3 millimeter in depth, and for A2 means that more than or equal to 3 millimeter and less than 5 millimeter in depth. Means that stromal invasion means that inside in the same line. Okay, but for the depth it is up and down. Okay, for invasion stroma means that in the same line, but if it is in depth means that up and down. Okay, this is for the stage 1A1, means as we said stromal invasion just less than 3. For A2 it is stromal invasion more than or equal to 3 and less than 5 millimeter in depth. Means that if he bring to you that it is 3, you will not go for A1 1A1, because 3 is included in the stromal invasion. So take care. If he said to you it is 3, means that it is stage A12, 1A2 I mean. Okay, and less than 5 in depth. For stage, this is for the stage 1. It is 1A and 1B. This is now 1A. About 1B, it is invasive cancer with major deepest invasion more than or equal to 5 millimeter, so greater than stage 1A. Okay, because the last one here it is 3 till 5, but I mean less than 5, because 5 it will be included in 1B1. Is it clear till now? Hello?
Yes, ma'am. Yes,
yeah.
ma'am.
What
Yes,
I
ma'am.
want to tell
Yes,
you,
ma'am.
you need the one who read this staging late need to be every day at morning to see it. Okay, even in the day of the exam. The one who is recall it every now and then and read it before, I mean يعني revise it many times, yeah, يعني it will be for him it's easy. But for the one who take it يعني late, better to every day like capsule BID. Really. It is like this. Okay, so at morning go and see the stage and what just read the stage and what is it beside it. Also I will post 2 papers by my handwriting for just what is it and what is the management. Okay, for you, for easy, for the cervical, for the endometrial, and for the ovarian cancer. Okay, just I will send it in my group. Okay, so yeah, just see it just for the exam. So for 1B, as we said, that it is means that it will go limited, still it is limited in the cervical uteri. But for 1B1, it is more than or equal to 5 in depth of stromal invasion and less than 2 in greatest dimension. For the B2, it is invasive cancer more than or equal to 2 centimeter and less than 4 in greatest dimension, means that it is now become invasive. Okay, it is not by depth, means that it is invasive more than يعني invade يعني beyond كده the stroma. Okay, so it is more than 2 and the greatest dimension is less than 4 centimeter in greatest dimension. This is for B2. For B3, it is invasive carcinoma more than or equal to 4 centimeter in greater dimension, means that the dimension by itself it is how much يعني. Okay, so it is in greatest dimension, it is more than or equal to 4 centimeter. Okay, again for the stage 1, still we are within the cervix. We are still within the cervix. Okay, For stage 1A, it is diagnosed only by microscope, and the maximum depth is less than 5 millimeter. Major stromal invasion less than 4 in depth, and major stromal invasion more than or equal to 3 millimeter and less than 5 millimeter in depth. This is for 1A1 and 1A2. For 1B, it will be invasive cancer, measured about more than or equal to 5 millimeter, greater than stage 1, and lesion limited to the cervix uterine. Okay? For the invasive carcinoma, as we said, more than or equal to 5 for the 1B1 and less than 2 in greatest dimension. And for B2, it is invasive carcinoma more than or equal to 2 and less than 4 in greatest dimension. For the B3, it is more than 4 as a greatest dimension or equal to 4. Okay? For stage 2, it will be the carcinoma invade go beyond the uterus, but not extend onto the lower third of the vagina or to the pelvic wall. Okay? So it is beyond the cervix, but not extend to the lower third of the vagina or the pelvic wall. Okay? For example, like here, this one. Sorry. So it is like it not go for the lower third of the vagina. Okay? For here, this one. Not go for the lower third of the vagina. Okay? This one. And this is for more than 4 for B2. Okay? For stage 3, it is go, but not go for the lower third of the vagina. Okay? Here like this, in this stage. Okay? So this is for stage 2. For A1, for 2A1, it is invasive, less than 4 in greatest dimension, and for 2A2, invasive carcinoma more than or equal to 4 centimeters in greatest dimension, and for stage 2B, it is with parametrial invasion, but not up to the pelvic wall. Okay? For the parametrium, but not the pelvic wall. So again, stage 2, confined, it is extend beyond the uterus, but not go for the lower third of the vagina or the pelvic wall. This is very important. For 281, it is the greatest dimension is less than 4, the invasive carcinoma, and also it is limited to the upper 2/3 of the vagina without parametrial invasion. For both of them. In 2A2, it is invasive more than or equal to 4 in greatest dimension. For 2B, with parametrial invasion involved, but not up to the pelvic wall. Okay? For stage 3, it involves the lower third of the vagina and or extend the pelvic wall and or cause hydronephrosis, non-functioning kidney, or involve pelvic and para-aortic lymph node. Okay? For 3A, 3B, and 3C, for 3A, we will go direct. It will involve lower third of the first one, lower third of the vagina, but not go for the pelvic wall. The second one, it will go for the pelvic wall, and even sometimes with hydronephrosis or non-functioning kidney, maybe in the question. Okay? For stage 3C, it will be pelvic or para-aortic lymph node, irrespective of tumor size. Okay? For the 3C1, pelvic lymph node, and for 3C2, it is para-aortic lymph node metastasis. Is it clear till now? So if he said to you para-aortic, you go immediately for stage 3C2. If it is pelvic lymph node, you will go to 3C1. It is simple like this. Okay? For the 4, it will be as 4A and 4B, it will be 4A spread to adjacent pelvic organ, and for 4B, it will be spread to distant organ. Okay? So, as I told you, revise it many times. The one who read it later, better to go with it every now and then. In the day, 2 times per day. Okay? Because it's very important. Okay, so apart from stage 1A1 and 1A2, where histological diagnosis is based on the depth and horizontal extent of the disease, the staging of the cervical cancer is based on clinical assessment. Most likely, it is not surgical assessment. Okay, and I have paper. I will send. I will in this slides. I will show you how very simple to know that the cervix and the cervical and the I mean for the ovary and the endometrial, it is surgical staging by surgery. but for the cervical and the vulval, it will be by clinical assessment. Okay? Clinical staging. So the FIGO for staging include colposcopy of the cervix, the examination under anesthesia, okay, and endocervical curettage, hysteroscopy, cystoscopy, prostoscopy. Okay, it is not routine to do all these. Just if you need, for example, because you know the cervix, it is an area very near to the bladder and very near for the urethra and this area. Okay, so you may need to do these things. And also intravenous urography. So X-ray examination of the lung and the skeleton, even when performed by an experienced clinician, clinical staging is inaccurate and unreliable. Okay, so this is area also of the exam, when to use MRI and when to use the CT. As we know, the MRI is superior to both the CT and clinical examination, okay, in determining the size, site, and extent of the cervical tumor. So if we need the MRI, we mean that we need to see the local extension, okay, not the distant metastasis or whatever. So we need to know this area. Is it clear for you? My voice is clear?
Yes, ma'am.
Yeah. Another thing I want to ask you, what is the types of the cervical cancer? We have two types. What is the common one?
Squamous.
Squamous is the common.
Yeah. So squamous, how much?
70%.
More than 90%?
80%.
75.
And adenocarcinoma? Yeah, the squamous cell is 80%. And about the adenocarcinoma, it is?
5 to 10%.
20%. So put it like this, 80 and 20, to be for you easy to recall. Okay, so 80 and 20. 80 is the squamous cell carcinoma. Okay? Okay, so for the MRI, as we said here, it is superior to both the CT and clinical examination in determining the site and extent of the cervical tumor. Okay, means that if it is in the early stage, you will go most likely with the MRI. Hello?
Yes, ma'am.
Yeah, and routine staging with early examination under anesthesia and cystoscopy may not be necessary unless there is discrepancy between clinical finding and MRI. Okay, means that to involve the cystoscopy, you need, if you have any problem with the MRI, you will go for examination under anesthesia with cystoscopy. Okay, MRI is best used, excellent for local staging and assessing for the invasive disease in patients treated with primary chemoradiotherapy. Take care. If the patient came to you in the scenario and just she's, for example, stage 3 with chemoradiation, and you want to, she came, for example, with recurrent or whatever symptoms or whatever, you will go for MRI because you need to solve the local area. Okay. In case of tumor recurrence, MRI is superior in distinguishing fibrosis from active disease. Okay. This is the area for the MRI. So for local staging, for recurrence and treated for patient if treated with chemoradiotherapy. Okay. CT and PET. Okay. If on MRI imaging, a small area of residual tumor is detected at the completion of the treatment, there is a window of opportunity to offer extensive surgery. Okay. And this woman most likely should then undergo the PET CT imaging prior to surgery to exclude lymphadenopathy and distant spread of the disease. Okay. So just let the azan. Okay. Hello?
Yes, ma'am.
Yeah. So as we said that if we have to exclude, for example, lymphadenopathy and distant metastasis, spread of the disease, we will go for the PET, which is the positron emission tomography. Okay, CT. This is the treatment of cervical cancer. Please يعني concentrate. Inshallah, it will be easy for you. Okay. It is area of SBA and EMQ. Very important. Okay. So first thing in the treatment of the cervical cancer is that the final treatment should be made in an MDT, which is a group of doctors, okay, including gynecologist, oncologist, and clinical oncologist, radiologist, and all these people should be with the patient, okay? And the aim may be either curative or palliative. Curative means that to cure means that to remove this tumor, and palliative means that just to improve her quality of life. Mean that she will have low, the pain will be decreased. For example, she can go for the bathroom, she can go like this. Okay, this is for the palliative. So for stage 1A1, for stage 1A1, okay, for stage 1A1, which we said, what is it? Stage 1A1. What we said before?
Less than 3 mm.
Yeah. For this stage, the majority of these cases are diagnosed on LITS or a cone biopsy. Okay, in this area, the incidence of the positive lymph node is less than 1% in the stage 1A1. Okay, so if the extension margin are clear of the disease, at that time, no further treatment is necessary. Just what you will do careful cytological and colposcopic follow-up is essential. So cervical screening and colposcopy means, okay, again, if the patient in stage 1A1 and diagnosed with LITS or cone biopsy, as the incidence of the lymph node, positive lymph node, is less than 1%, so no need to remove the lymph node. The second thing is that if the excision margin are clear of the disease, means that no need to go further. So no need to do anything else. Just careful cytological and colposcopy treatment is enough. But if the excision margin are involved, then you need to have further local excision should be performed, or a simple hysterectomy be considered, particularly when there are other gynecological indication and fertility is no longer an issue. Okay? Is it clear? Hello?
Yes, ma'am.
Yes, ma'am. Yes.
Yeah.
Hello,
So,
sorry. So this is if there's no clear margin when we do the lead and we find carcinoma, then we have to offer hysterectomy.
yeah, it is clear, my dear, because no time. That's why I want to go fast, okay? So it is very clear here. It is if it is clear of the margin, no further treatment. If it is involves the margin, you will go either to local excision if there is, for example, fertility issue, or simple hysterectomy. You will go if there is no fertility issue. Okay? If simple hysterectomy is chosen, at that time, what you do in the presence of incomplete margin, a repeat loop or cone should be performed to exclude more extensive invasive disease that could necessitate a radical hysterectomy. I will explain. Okay? Means that if, for example, he tell you that I want, you will do hysterectomy. خلاص, you will do simple hysterectomy. Before you will do simple hysterectomy, you should do another, another either repeat loop or cone just to make sure that there is no extensive invasive disease. Okay? Because if there is extensive invasive disease, you will go for radical hysterectomy. Is it clear?
Yes, ma'am.
Yes, ma'am. Yeah. So means that if they said in the question, in the exam question, that this patient, she's stage 1A1, okay, and she, for example, her age is 48 or whatever, you will go for, and you did for her LITS or cone biopsy, and she's for simple hysterectomy. He will ask you what you will do before he tell you about simple hysterectomy. Before you will go for simple hysterectomy, if you found that there is repeat loop or cone biopsy, you will tick this, okay, to exclude more extensive invasive disease. Very important, this area. Okay.
Sorry, ma'am. The local excision you talked about, is it not also a repeat cone or LITS, or is just local on that particular area?
I didn't get you. Sorry. What's your question?
All right. You said when a cone mostly is diagnosed on either LITS or cone biopsy, and if the margins are clear, no further treatment. But if the margins are involved, then we have to do either local excision or a simple hysterectomy. So I'm asking on the local excision to say, local excision that is being done, is it another LITS or another cone biopsy, or it's just local?
Yeah, it is local, or local excision means that either LITS or cone biopsy.
Okay. And then also on simple hysterectomy, you also do that. So it's like we are doing local on both, the local on itself as well as together with hysterectomy.
Yeah, the local excision will be in both. Exactly.
Okay.
In simple hysterectomy, before his simple hysterectomy, and the other one, if there is any fertility issue, you will do, for example, cone or LITS.
Okay,
But you should tell the patient that her management is simple hysterectomy. The patient should know this. And you will
Doctor, for stage,
okay?
Doctor, for stage 1A1, which is the preferred treatment? It is LITS or it is cone biopsy?
It is as per the new one, LITS. I think LITS the one which will do it.
Because there are many questions in all the practice book. They always ask either LITS or cone biopsy. So what we should select?
Most likely LITS.
LITS,
okay. Yeah.
Dr. Rasha, if it is the age doesn't matter, if the margins are not clear, so should we go for hysterectomy for less than 50 and more than 50 for everybody?
Yeah, it is simple. It is, if the margin is not clear, you should do simple hysterectomy. Yani be considered, I mean.
So even for less than 50 also for everybody?
Yeah, it is clear here, my dear. Further, it is if the excision margin are involved, then further local excision should be performed. Okay, or simple may be considered, particularly when there are no other gynecological indication and there is no fertility issue. Okay. But take care. It will be consideration. But perform. Okay. Just let us go. For stage 2. Sorry. 1A2, the optimal management of stage 1A2 is uncertain since there is not a clear evidence base. Okay, so it means that there is no optimal management for this 1A2. Anyone can remember me what is A12?
It is up to 3 to
It
5
is
mm.
again microscopic.
Microscopic, 3 mm to 5 mm. More than More than or equal to 3 mm to 5 mm.
Less than 5 mm.
Okay, so the incidence of the positive lymph node in this is approximately 5%. So what you will do modified radical hysterectomy plus pelvic lymph adenectomy have been performed, to be performed. Okay, so this is for the stage 1A2. If medically unfit, you will go for radical radiotherapy. If, for example, she wants to preserve her fertility, you can still be cone biopsy or LITS. Okay, is it clear till now?
Yes, yes.
Yes, ma'am.
Yeah, this is very important. You should know it because it can come in the exam. Really, it's area of exam. So stage 1A2, it will be because the positive lymph node, approximately 5%, you will go for modified radical hysterectomy plus pelvic lymph adenectomy to be performed. If medically unfit, you will go for radical radiotherapy. If she wants, for example, to preserve fertility, you will go for cone biopsy or LITS. Okay,
ma'am, I think if she wants to preserve fertility, it will be radical trachelectomy and laparoscopic lymphadenectomy. I don't know.
Can be cone biopsy or LITS. This is in the second stage, but this is now till here. It is cone biopsy or LITS. Okay. For stage 1B and 2A, the option for treatment are radical hysterectomy and bilateral pelvic lymph adenectomy or radical radiotherapy with equivalent cure rate. Okay. So the treatment is either radical hysterectomy and bilateral pelvic lymph adenectomy or radical radiotherapy if the patient is unfit for medically unfit. The cure rate is the same. Okay, the medically fit younger patient is treated with surgery. Okay, as unfit older patient treated with radiotherapy. So for the stage 1B and 2A, it is, as we said, radical hysterectomy and bilateral pelvic lymphadenectomy or radical radiotherapy. What do you mean by radical hysterectomy? Anyone can tell me? Hello.
Going up to the pelvic side wall, like it is a type 3 hysterectomy. Modified radical is type 2, where we go midway between the uterine peritoneum and the pelvic side wall. In type 3 or the radical, we go up till the pelvic side wall and dissect and take out all the tissues.
Yeah, exactly. Excellent. So the surgery, which will involve removal of the pelvic lymph node from the common iliac artery to the femoral canal, if you go for to remove the lymph node. There is no clear rule for the routine removal of the para-aortic lymph node. So no rule for routine. Okay. For women with early stage, for example, stage 1B1 or less, tumors less than 2 cm in diameter, where there is a strong desire to retain fertility, a radical trachelectomy may be offered. Okay. So for the radical trachelectomy, the patient should be on stage, يعني it will be stage 1B1 or less. And the tumor will be less than 2 cm in diameter. Okay? So you will do for her radical trachelectomy and bilateral pelvic lymphadenectomy. Take care. This is area of exam. Patient want to preserve fertility. You account for her stage, and you found her stage is stage 1B1 or less, and the tumor is less than 2 cm. Okay? And she want to retain fertility. You will offer, not consider. Offer her radical trachelectomy and bilateral pelvic lymphadenectomy. Okay, and this will involve removal of the cervix and paracervical tissue and aim to conserve the uterine body. Okay, clear till now?
Okay, ma'am.
Yeah. Okay. So the patient should be counseled carefully because there is an impact on this on her pregnancy. Okay, there is implication for future pregnancy, including increased risk of the miscarriage and preterm delivery. The operation can be performed by vaginal, abdominal, or laparoscopic route, as well as robotically. Okay, and there is, which we call it Sherdokhar suture, is inserted simultaneously into the uterine isthmus to reduce the incidence of cervical weakness. Okay, so if you do this surgery, the radical trachelectomy, we should do this Sheddukhar suture. Okay. If the surgical margin are close to the tumor or the lymph node are involved in the tumor, adjuvant pelvic radiotherapy should be considered. Okay.
Dr. Rasha? Dr. Rasha? Can I ask a question?
جماعة
I
أنا
need
بستلم الأسئلة خلوها بعدين. Better to ask me in private because really يعني no time.
I need best to ask what is the type of hysterectomy. I'm confusing in understanding it. What is the difference between radical and modified radical and simple hysterectomy?
Anyone he know what is the difference between simple, radical, modified, radical, and radical trachelectomy? Tell us. Hello. Hello.
Yes,
Yeah,
ma'am.
so in simple
What about
hysterectomy, in simple hysterectomy, it's extrafacial. We just cut all the structures as close as possible to the uterus. We are not going to leave in. We are not going to take anything extra along with the specimen of the uterus. Whereas in whereas in modified radical, we take some part of the vaginal cuff and then a few centimeters of the artery, and whereas in radical, from the origin itself, we'll cut the uterine artery and most of the vaginal cuff, everything will be excised. So based on the severity,
radical hysterectomy
we go for a more radical one.
Yeah, and also the upper part of the vagina. This is for the radical hysterectomy. Am I right? Hello?
Yes,
Hello?
Yes, ma'am.
Yes. Along with uterosacral ligament.
Yeah, it is for the throat. Hello?
Hello,
My voice
ma'am.
is clear?
Yeah, ma'am. Yes, ma'am.
Okay, thank you, doctor. Thank you. Thank you.
Yeah. For the simple, it is just the uterus. For the radical hysterectomy, you will remove all, even the upper part of the vagina, the ovary and the nearby tissue and all these things. Okay?
Okay, thank you. Thank you.
Yeah, and you are welcome. And for the radical trachelectomy, as we mentioned before, in this slide, what you will remove, okay? Cervix, paracervical tissue, and aim to conserve the uterine body. And also with the lymph, you will take the lymph node, okay?
In the simple, we leave the ovaries behind? Simple hysterectomy, we don't remove
the simple
ovaries.
will not remove the ovary, yeah.
And ma'am, what about modified radical?
Modified radical?
Yes, what about modified radical?
Radical, modified radical, there is nothing related with the ovaries, whether you are removing ovaries or not. It depends on the stage of the cancer, and it depends upon your discussion with your patient. Modified radical hysterectomy is separate entity, and whether you are removing ovaries or not, that is a separate thing.
Yeah, most likely the modified radical hysterectomy is that you will remove the uterus, also the cervix, and also like upper 1 to 2 cm of the vagina. Okay, even with the parametrial tissue surrounding this organ. So it means that the modified radical, it is the same as radical hysterectomy. Okay, and most likely in the modified radical, maybe from the radical is that you will involve the lymph node. Okay.
From 1A2 onwards, lymph nodes always are removed. Only in 1A1, lymph nodes are left behind because it's less than 1%. But from 1A2 onwards, lymph nodes have to be removed bilaterally.
Yeah, as we mentioned. Okay, so for the radical chemoradiotherapy, what about it? How it is? It is weekly cisplatin. If he asks you about the chemoradiotherapy, the radiotherapy chemotherapy that's used in the cervical cancer, it will be they will use weekly cisplatin plus daily external beam radiotherapy, which is telotherapy. Okay, and which we call it because telotherapy means that external beam, and it will be on outpatient basis for 5 weeks, followed by an overnight stay for insertion of the central radiotherapy, which is a brachytherapy. Okay, means that it will be inserted direct to the cervix. Okay, when we will do radical trachelectomy, if the patient wants to preserve fertility, if the tumor size of the stage 1B1 or less, and if the tumor less than 2 cm. Okay, for stage 2B and 4A, here the radiotherapy is the primary mode of treatment with chemotherapy. Okay.
Yes, ma'am.
Yeah, the dose of the radiotherapy can be reduced in the very frail and where the intention is palliative rather than curative, means that the very frail old lady, for example, for medically fit patient with advanced central pelvic disease and no evidence of metastasis, you will choose the pelvic excenteration. Okay, means that it will be a big surgery, and this is most likely it will be if the patient is fit. The most important thing is that the patient is fit and it is advanced central and no evidence of metastasis. Okay, this is candidate for the pelvic excenteration to be considered. The excenteration, what do you mean by excenteration? It will be involve removal of the tumor and the adjacent structure, which can include large bowel, bladder, and vagina. And the surgery alone carries a 2 to 4% risk of mortality. So the excenteration, the risk of mortality in it is 2 to 4%, very important. Okay, with a 5-year survival of 30 to 60%. So it should only be undertaken in a cancer center and only by a surgeon performing this type of surgery on a regular basis. Okay. The dose of radiotherapy can be reduced in the very friable. I think this I read this. Sorry.
Yes.
Yeah. So for stage 4B, it is palliative, as we said, and it will include it is mainly radiotherapy, and it will be useful for the symptoms control, especially for vaginal bleeding. Okay. Is it clear till now?
Clear, ma'am. Clear.
Yeah, just we'll say about summary. A careful assessment of the extent of the recurrence is essential with MRI, followed by MDT. Okay, and examination under anesthesia and PET-CT may provide additional information regarding the presence of occult disease and distant metastasis. So if he said to you that the patient, for example, he did, surgery, or what she did chemoradiotherapy before, he said like this, so most likely you will go for MRI. Okay, because it will show for us the local extension. It's clear. Excellent. For the PET and AU, okay, AEUA, it will be if you, for example, you didn't get benefit from the MRI, you will go for this to provide us with if there is any presence of occult disease and distant metastasis. If there is a pelvic recurrence following primary surgery, the usual treatment is radiotherapy with or without platinum-based chemotherapy. Okay, and if there is an isolated central pelvic recurrence following radiotherapy, then a pelvic excenteration should be considered. Means that if there is recurrence and you start by surgery, you will go for radiotherapy or chemoradiotherapy. If you start by chemoradiotherapy, you will go for surgery in the management of recurrence. Okay, is it clear?
Yes.
So for example, here he starts by for example, there is isolated central recurrence following the radiotherapy, means that there is no surgery, so you will go for surgery for the treatment of the recurrence. But you should, before you go for the pelvic excenteration, you should make sure that it is central recurrence, medically fit patient, advanced central disease, and no metastasis. Okay. Okay, so excenteration can be anterior when the bladder is removed, posterior when the rectum is removed, or total when both are removed. Okay, what about the cervical cancer in pregnancy? This is very important actually area, and it is from the FIGO, the last one. Okay, so in the FIGO, just I will simplify it for you. Just it is, for example, most likely if we have cervical cancer in pregnancy, most likely will be very rare. Cervical cancer in pregnancy is very rare. This is the first thing you should know it. Okay. The second thing is that the MRI is most likely safe. Yes. Hello.
Yes.
Yeah, hello.
Yeah. So most likely the challenge in this cervical cancer in pregnancy is that the risk of this woman to continue her pregnancy. Okay, and to balance this again is the risk of preterm delivery and these things. Okay, so most likely the treatment for any cancer, you should proceed direct for treatment because you know it is a cancer يعني. Okay, and especially if the diagnosis is made before 20 weeks, you should go direct to manage. Okay, the critical area is that when the patient, for example, is for example beyond the 28 weeks, because most likely the fetal viability is more problem in this area, and the patient should be taken corticosteroid and these things. Okay, so the difficulty I mean it will be easy for you if it is less than 20, because still viability not, and if it is more than 28, because just it will be corticosteroid and you deliver the patient. But the problem is that if the patient is between 20 and 28 weeks, this is the critical area. Okay, yeah, and also especially for example if it is stage 1B1, because the treatment in this it will be delayed. Okay, it will go most likely for the lymph node in this area. Okay, so as per the last figure for the cervical cancer in pregnancy, stage 1A1 can be managed by conization and is best done between 12 and 20 weeks of pregnancy. Okay, if it came to you scenario with stage 1A1 and the patient is between 12 and 20 weeks, the management will be conization or cone biopsy. Okay, sorry, my voice is clear?
Yes, ma'am. Yes, ma'am. Clear.
Yes, ma'am. Clear.
So, yeah, as per the last one, as I mentioned, if it came to you stage 1A1, it will be between 12 and 20 weeks of pregnancy. Okay, and you can found it as conization or coin biopsy. Okay, it's used sometimes in pregnancy to highlight that the incision shouldn't be deep enough to cause damage to the fetal membrane. This is best performed in theater with adequate anesthesia, and prophylactic cerclage may be an option both for prevention and of preterm labor and management of operative bleeding. Is it clear? So here the cerclage is for two things: for prevention of preterm labor and for as management of operative bleeding. Okay, for stage 1A1 and stage 1B1, which is less than 2 centimeters, this is either conization or simple trachelectomy. Okay, and can be performed because parametrial extension is seen in less than 1% of the women. Okay, simple trachelectomy is a less complicated procedure and is defined as excision of the cervix 1 cm above the tumor border. Okay, so for 1A2 and 1B1, he didn't tell anything about the about the gestational age. He said that either conization or simple trachelectomy means that the body will be preserved. Okay, and why? Because the I think better to Dr. Amani, better to check your connection. Okay, so conization or simple trachelectomy may be performed because of the perimetrial invasion and because it is less than 1% of the women. Simple trachelectomy is a less complicated procedure and is defined as excision of the cervix 1 cm above the tumor border. Okay, it is necessary to assess lymph node status by laparoscopic pelvic lymph adenectomy before conservative surgery. And in the event of the node positive, the woman should be told that immediate treatment is recommended. Okay, and if it is before 20 weeks, it is most likely you will best to perform laparoscopic lymphadenectomy. Again, if this operation, simple trachelectomy, you found that you should assess the lymph node, and if you found that the lymph node the assessment will be by laparoscopic pelvic lymph adenectomy before conservative surgery. Okay, so means that in the scenario, if it came to you and still there is no treatment, the first thing is that to assess the lymph node by laparoscopic pelvic lymph adenectomy before conservative management. Okay, and in the event of the node is positive, the woman should be told that you should this patient should start her recommended treatment. Means that she should treat this patient, because most likely there is lymph node involvement, means that there will be more danger about for her life. Okay, so laparoscopic lymphadenectomy is best performed before 20 weeks of pregnancy. Okay, abdominal and vaginal radical trachelectomy have also been performed during pregnancy with variable pregnancy outcome. Okay, abdominal and radical trachelectomy is technically more challenging and is associated with significant blood loss and prolonged surgery. This is as per the FIGO, the last one, 2018. Okay, obstetric outcome is poor, and therefore radical trachelectomy is not recommended during pregnancy. Okay, so the recommended one is the simple trachelectomy, but you should assess the lymph node. If you found that the lymph nodes are involved, you should go for laparoscopic lymphadenectomy. Okay, between abdominal and vaginal radical trachelectomy, okay, the abdominal one is dangerous. There is significant blood loss and prolonged surgery, and the obstetric outcome is even will be poor. So radical trachelectomy is not recommended during pregnancy. You should know this. Okay, we will summarize it, don't worry. I know it is now. Yeah. Okay, for stage 1B1. Okay, for stage 1. So now we finish what? Sorry. Now we finish this one, 1A1. Again, just summarize. Well, I don't want you to be to get upset because no time. Okay, so just I want to summarize for you. If the patient came to you and you diagnose that this is stage 1A1, you will manage by conization, especially if she is between 12 and 20 weeks of pregnancy. You will either choose conization or cone biopsy. Okay, because why? Also, it is best performed in theater with just liquid anesthesia. Okay, and there is a risk of preterm labor and management of operative bleeding. Okay, so that prophylactic cerclage may be an option for both prevention and as a management of operative bleeding. Okay, for stage 1A2 and 1B1 less than 2 cm, you will go for either conization or simple trachelectomy, and you should assess the lymph node. If you found the lymph node is positive, you will go for laparoscopic lymphadenectomy. Okay, and after that, you will go for example, for between the abdominal and vaginal radical trachelectomy, better to go for vaginal one, because the abdominal you have a significant blood loss and prolonged surgery, and the obstetric outcome is poor, and therefore radical trachelectomy is not recommended during pregnancy. Okay, let's go for the stage 1B1 tumor larger than 2 cm. Okay, this is most likely will be treated with neoadjuvant chemotherapy with or without pelvic lymphadenectomy. Okay, what do you mean by neoadjuvant chemotherapy? We mean that we will give the patient chemoradiation. Okay, it will decrease the stage of this patient. For example, it will be lower in the stage, and it will be easily removed during surgery. Okay, this is a neoadjuvant chemotherapy with or without pelvic lymphadenectomy. Chemotherapy is relatively safe in the second trimester, although there is a higher risk of preterm labor, premature rupture of membrane, and fetal growth restriction. So you should know that the risk of chemotherapy is preterm in second. It is safe in the second trimester, but also there is a risk of preterm labor, premature rupture of the membrane, and IUGR. Okay, the neoadjuvant stabilizes the tumor until fetal maturity is achieved, so that cesarean delivery and radical hysterectomy can be performed. Okay, so means that if you did the neoadjuvant chemotherapy, most likely it will be safe in the second. By this, you will preserve the baby, and you will do cesarean section at the end, and with the same procedure, you will do radical hysterectomy. Okay. Is it clear till now? Hello?
Yes, ma'am. Yes, ma'am.
Yeah.
Yes,
In
yes.
the advanced pregnancy, for example, 22 and 25 weeks, pelvic lymph adenectomy is not possible, and those with stage 1A1 to stage 1B1 most likely can postpone definitive treatment until fetal maturity is achieved without compromising the survival. Okay? For the neoadjuvant chemotherapy can also be given for locally advanced cancer and in advanced pregnancy to preserve pregnancy until optimal fetal survival is reached. Okay? So in summary, for the tumor 1B1 and larger than 2 cm, you will go before the operation, this one, the radical hysterectomy and cesarean section, you will go for the neoadjuvant chemotherapy, okay, with or without lymphadenectomy, okay? And you should take care that the chemotherapy have a risk of preterm labor, PPROM, and IUGR, okay? For the neoadjuvant chemotherapy can also be given for locally advanced disease and in advanced pregnancy to preserve the pregnancy until optimal survival 35 and 36 weeks is achieved. This is, I think, the last one, I think, in this. Yeah, okay, in the cervical cancer. So cesarean delivery followed by radical surgery or definitive chemotherapy or radiotherapy showed good obstetric and oncological outcome. Cesarean delivery is the preferred choice for delivery of the fetus in the presence of the bulky tumors. Vaginal delivery risk the possibility of catastrophic bleeding and implant metastasis in vaginal tears or episiotomy scar. Take care. She has a risk of metastasis with the vaginal delivery. So most likely the preferred one is a cesarean delivery. So if she bring to you in the scenario delivery for patient with cervical cancer, go for cesarean delivery. Okay, especially if the advanced or these things. In a locally advanced tumor, a lower segment cesarean section should be avoided owing to the risk of the cutting or tearing into the tumor tissue. So it means that if it is locally advanced, a lower cesarean should be avoided. A classical, I mean, يعني phalangeal station, or I mean the lower segment. No, phalangeal it is outside. The lower segment transverse cervical cesarean delivery, it will be avoided, but the better one is the classical one because you will avoid the area of bleeding, okay, by the classical incision. As we know, the classical incision, this is the uterus, you will go just direct like this. Okay, so you will minimize by this the blood loss and avoid the large tumor vessels. And where pregnancy preservation is not desired for, or in advanced cases, pregnancy termination and the treatment as in non-pregnant woman is advocated. Okay, if the patient, for example, she didn't desire this pregnancy or in advanced disease, you can go for termination after counseling with the patient, of course. In early gestation, less than 12 weeks, spontaneous abortion occur after pelvic irradiation. In second trimester, hysterectomy followed by definitive chemoradiotherapy is preferred because obstetric complications are fewer. Hysterectomy, I mean. In the second trimester, hysterectomy is better, followed by definitive chemoradiotherapy because of obstetric complications are fewer. Okay, means that if you have the patient and she is, for example, in advanced cancer and it is in the second trimester and she told you that I want to preserve my pregnancy and she agreed after a long time and after some time that she want to do, you will do for her hysterectomy to preserve the baby. Okay, followed by chemoradiotherapy because obstetric complications are fewer. Okay.
Yes, ma'am.
Is it clear till now? Okay, so this is the 5 survival rate are.
Ma'am, I have a question. If a patient comes with the advanced disease in the first trimester of pregnancy, then what should be the treatment? If we would terminate the pregnancy, or we will give the treatment to her?
What he said here, in advanced disease, in early gestation, less than 12 weeks, spontaneous, you will go for pelvic radiation if it is advanced disease. But you should tell the patient and to tell her about the risk that there may be a spontaneous abortion. Okay?
Okay, ma'am. Okay.
Yeah. This is the 5-year survival rate. Okay. It is, I think, from, this is from the Cancer Research, UK. It is simple, like, for example, for stage 1. Just 1 minute. Yeah, it's very simple. For example, for stage 1, it will be more than 90. Okay, more than 90, as you see. For stage 2, for example, here, it is between 90 or more than 90, it is most likely. For stage 2, okay, it is from 50, as we say here, it's from 50 to 55, for example, if you take the average. Okay, for stage 3, it will be from 30 to 40, for example, just to beg for you, to be easy for you. For stage 1, as we said, more than 90. Stage 2, 50 to 55. Stage 3, 30 to 40. Okay, and for stage 4, it will be maybe sometimes less than 10%. Less than 10%. Okay. Yes, so again, the 5-year survival for stage 1, more than 90%. For stage 2, 50 to 55%. For stage 3, 30 to 40%. For stage 4, less than 10%. 5-year survival for cervical cancer. This as per the Cancer Research Center, because today I searched for it. Okay.
So, Dr. Rasha, we have to follow this one, 5-year survival, or the one we were just seeing everywhere like FIGO? Which one we have to follow?
Either FIGO or the Cancer Center, UK. You will follow this most likely. Most likely. Okay. Yes, ma'am. Yeah, just let me to pray, just 5 minutes or 8 minutes, and then we will come back, because also I want to finish on 1 hour or more, less than 1 hour. Okay, just let me to pray. Okay.
Okay, ma'am.
Can anyone repeat what is the most common female and gynae cancers? Does anyone know the list again?
For the female, the first one will be the breast. The second one will be the bronchus. The third one will be the GI tumors. The fourth one will be the fourth one will be the endometrial tumor. The fifth one will be melanoma, and the sixth one is the ovarian tumor.
Okay. And in gynae, it's endometrial, ovarian, and cervical, right?
Endometrial, ovarian, cervical. Yes, all right. Yeah.
Okay. Thank you. Thank you.
Welcome.
And one more question. These were the this was a list for the most prevalent cancers. But if we say the cause of death, then
The lung will be the first one then. The lung will be the first one,
one
and
will
then
be the
followed by.
ovarian tumors.
I think it was lung. Someone's somewhere I read lung. Yeah.
Yes, lung.
Yeah.
It was if it is the most common cancer causing the death in the female, it is the lung. Then in that case, it is lung, and then the second one is the breast, and the third one is bowel cancer, like same the other. So the difference between breast and lung.
So the list that we have: breast, lung, colon, endometrium, melanoma, ovarian. This is just
Hello?
prevalence.
Yeah, it is according to the prevalence, and then the other one with lung, breast, it is according to the most common tumor causing the death in the females, like that. So lung is the number one.
Okay, so let's start. Yeah, so let's start. Who will go with this first question?
I'll take one or two, ma'am.
Yeah.
Okay. The patient is a 37-year-old multiparous patient who presented with a high-grade glandular smear abnormality. No abnormality was detected at colposcopy, and a large loop excision of the transformation zone was performed, which showed high-grade cervical glandular intraepithelial neoplasia and adenocarcinoma of less than 1 mm depth. The endocervical margin was incompletely excised. A cone biopsy was performed, which showed further high-grade CGIN at the endocervical margin. The patient also complained of menorrhagia and her family was complete. So we should do a simple hysterectomy, ma'am.
Yeah.
Margin positive. So we
Yeah.
they have already done a test. They have already done a leads again. So we will
Yes.
directly go to simple hysterectomy.
So we'll go for the total. Total abdominal hysterectomy.
Yeah, total abdominal hysterectomy.
Which is I. Yeah, exactly. Excellent. Next question. Yeah.
A lady 51 years age presents with a 5 centimeters well differentiated squamous cell carcinoma replacing the cervix. So it is 5 centimeter macroscopic, 51 years lady. MRI scan showed evidence of early parametrial extension with no lymph nodes. So she becomes 2B stage. Cervix chest X-ray was normal. She was treated with a radical chemoradiation and had complete resolution of her tumor. At 12 months later, she presented with bleeding and was found to have biopsy proven central recurrence of her tumor with no evidence of any lymphadenopathy or distant spread. She wishes to pursue any curative option. So since we have already given her a chemoradio and now it's a recurrence, so we'll prefer giving her a surgery because there's a central recurrence.
Yeah. So because he started with chemoradiotherapy, so most likely this patient will go for what?
Pelvic excenteration.
Yeah, pelvic excenteration. So total pelvic excenteration. Okay. And also here written the present with 5 centimeter squamous cell carcinoma replacing the cervix. Okay. MRI show evidence of early parametrial. Yeah, exactly. Okay. So this is most likely recurrent. Excellent.
The patient is a 25-year-old nullipara patient who presents with a severely dyskaryotic invasive smear. She is found to have a 1.8 centimeter tumor, which is found to be well differentiated squamous cell carcinoma on biopsy. MRI shows the tumor is confined to the cervix with no lymphadenopathy. She is keen to maintaining her fertility. So it's less than 2 centimeters. There is no metastasis or lymph node that is there. So I can offer her a simple trachelectomy, ma'am. Let me see. Then here it fits into radical trachelectomy and pelvic lymphadenectomy.
Pelvic lymphadenectomy. Yeah, exactly. So the answer is will be radical trachelectomy and pelvic lymphadenectomy. Okay, because this is the most the only option. It can be plus or minus pelvic lymphadenectomy, as we said before. Okay.
Right. This only we did, na ma'am, just now. The patient is a 27-year-old nullipara patient who presented with a severely dyskaryotic smear. At colposcopy, an abnormal area is removed, revealing widespread CIN3 with foci of early stromal invasion. The pre-invasive and invasive components are both completely excised. So since it has been completely excised, we can follow her up with a test of cure at 6 months, like a test of cure at 6 months with a high-risk HPV followed by cytology and colpo.
This is the option. This is the option.
This is the answer. This is the.
I mean, this is the options.
I felt it should be no further treatment, only follow-up should be there because it's negative margin.
Yeah, no further treatment actually, no further, no further treatment. Do not do anything. Am I right? Because the patient already you did, and there is completely exists, and her age is less than 50. You remember?
Yes.
Age is less than 50, and what else? The criteria not to re-exist. What is it? I want you to recall this. The age is less than 50, and what else?
If the age is less than 50, and even if there is something
no evidence of glandular disease.
Yes. And what? The third one?
No invasive margins. No invasive margins.
No invasive and no glandular. Yeah. Excellent. Exactly. So no further treatment. Okay.
I'll continue, ma'am.
Okay, no problem. So okay, خلاص. Thank you, my dear. Hope you all the best. Yeah, thank you. Inshallah, you will do well. Inshallah. Who want to share this? Please, you want to go fast because I want to enter for the endometrial cancer. I want to finish just within 1 hour. Okay.
Okay. A 32-year-old woman presents as an emergency with vaginal bleeding. She has never had a smear test. Clinical examination reveals a mass replacing the cervix, extending onto the vagina and into the parametria bilaterally. Initial blood test shows acute renal failure with markedly raised serum urea and creatinine. Imaging shows a 6 centimeter cervical mass with the parametrial spread and bilateral hydroureter and hydroureter. Renal cortical thickness is normal. So it is stage 3B, ma'am.
Yes, 3B. Excellent.
So
what you will do? This is bilateral hydronephrosis and hydroureter.
Elevated urea and creatinine is there. So I'll go with option D, ma'am.
Yeah. You will go to insert bilateral nephrostomy plus or minus ureteric stent. Yeah, exactly. Because now you go for renal failure this patient. Okay?
Yes, ma'am.
So this is the answer. Excellent. Okay. Next question.
A 25-year-old woman has multiple biopsies of her cervix at the colposcopy clinic due to high-grade dyskaryosis. The histology shows CAN3 with areas of microinvasion. What is the most appropriate advice regarding her management? So it is CAN3 lesion with areas of microinvasion, ma'am. We can go for LEDS technique. E option, ma'am. Has an excisional biopsy using LEDS.
Yeah, using all other technique. Exactly. C. So it is A. C. Yes.
It's E option actually. No?
Yeah, C option. Okay. Exactly. Okay. You see this one, I do it because I remember it from my previous studying. You are now studying, okay? So the word O for ovarian, okay? And the word, the letter U for the uterine cancer. Both of them are studying. The S is surgical staging. S. To be simple for you to remember, okay?
Ma'am, for cervical cancer, we need clinical plus MRI for staging.
Clinical, yeah, but most likely for the ovarian and uterine cancer, it is surgical staging. This is exam question. For the cervical, it's clinical, and for the vulvar, it's clinical also staging. Okay, so you ovarian, O ovarian, and U uterine, and for the studying, it is S for surgical and S for staging. Okay.
Okay, ma'am.
Yeah. So let's go for endometrial cancer. It is considered to be, before we will start the endometrial cancer, as we know, it is with good prognosis. For just a minute. Yes. So most likely this endometrial cancer, it is relatively less aggressive when compared with other malignancy, because it most likely the patient, she will have vaginal bleeding and she will come for you. Okay, so most likely it is with good prognosis, and because it will be detected early. The majority of the established risk factor stem from the unopposed exposure of estrogen by progesterone on the endometrium, and this is the theory for the cause. Okay, that the endometrium exposed for estrogen without progesterone. Okay, so the risk factor, most likely it will be the age, and the peak incidence is between 60 and 79 years of age. 2 to 5% of the affected women are younger than 40. This is one of the risk factor. Okay, and late menopause is a risk factor. The parity, okay, because about 21 to 34% of affected women are nulliparous. Okay, so nulliparity is one of the causes of the endometrial cancer. Is it clear? And the pregnancy and the parity reduce the risk of endometrial cancer by 30% after the first birth, and by 25% with each subsequent birth. Okay? What is the risk of endometrial cancer in postmenopausal bleeding? Hello?
It's 10%?
10%. Okay. 10%. Yeah, 10%. And what about, for example, as a postmenopausal, for example, discharge with pus, which we call it pyometria. The risk of cancer in postmenopausal women with pus cell and yani postmenopausal discharge.
40%.
40%. Yeah, 50%.
Russia.
It is 50%.
50%.
Yeah, it is near. Yeah, 50%. Okay, you should know this thing.
Biometry, yes.
Yeah, exactly. And also regarding the endometrial cancer, as in the worldwide, it is number, which number as a worldwide for the endometrial cancer? It is actually, as we said, as a gynecological. Huh?
Third number worldwide.
The fourth.
Worldwide, it is number 6. Worldwide, it is number 6. But for the gynecological cancer, as a common, the first one. Yeah, exactly. Okay, and it is as overall for all the malignancy in the, it is about the 14th overall for the female. Okay, in UK. The most important thing that you should know, that it is the first gynae cancer in UK. This is the first thing you should know. Regarding the worldwide, it's the 6th one. Okay?
6 or 4th? Sorry.
6th one. The 6th one. Number 6.
Okay.
Worldwide.
Thank you.
Okay? Yeah. And also, as we said, that it is actually less aggressive, so that it will be detected early. But you should put in your mind, for example, if the patient with postmenopausal bleeding is 10%, this is not, always came in the exam, this question. Okay, and also the risk factor, for example, the the risk of, for example, the pregnancy, to reduce the risk is by 30%, and 25% with each subsequent birth is also important. Okay, and the pathology is by unopposed estrogen. Okay, for the obesity, as we know, the obesity play a role in this, and most likely, what is the cause for this? Anyone can tell me?
Peripheral conversion of the
Hyperestrogenism.
The androgen to
Hyperestrogenism.
Yeah, exactly. So it's one of the cancer most strongly associated with obesity. 3 to 10-fold increase in the risk due to increased steroid conversion to estrogen plus decrease asexual hormone binding globulin, and associated with hypertension and type 2 diabetes mellitus. Okay, very important. It's estimated that 36% of endometrial cancer is attributable to obesity. Very important, 36% of endometrial cancer is related to obesity. Okay, most active women have 23% risk reduction. Okay, so means that the thin or the active woman, the risk reduction is by 23%. The cigarette smoking, it is decreased by it will decrease the risk actually because of the anti-estrogenic effect of nicotine by 20 to 40%. Very important. Okay. The unopposed estrogen therapy, the risk increased by 6 to 8 times with the unopposed, as we know. And we have, for example, the HRT, about the million woman study, which is a trial done. It was described that the woman on estrogen only HRT had a 50% increase in endometrial cancer because unopposed estrogen, while those with on tibulone had an 80% increase in endometrial cancer. Okay, so it's better than tibulone. A later study then showed that women on the continuous combined HRT had a 76% reduction in the endometrial cancer, while women taking sequential had 70% increase in the risk. This is no need to read it now. I think this is just a waste of time. The oral contraceptive with high estrogen is a risk factor in premenopausal women. Okay, women on the low dose estrogen had a 6% risk of reduction for every year they were on the pill, and the effect lasted for up to 20 years. This is important. One of the exam question actually is that the low dose estrogen for the COG with the combined pill had a 6% risk reduction of every year because you suppress the ovary from producing estrogen. Okay, so because of the fewer days of unopposed estrogen exposure, and also you suppress the ovary to produce even the hormones. Okay, for the liver cirrhosis leads to decreased degradation of estrogen, which increase the risk of endometrial cancer. If you have any liver problem, the metabolism of the estrogen will be decreased, so that will increase the risk of the endometrial cancer. And for the PCO, as we know, more common in cases with history of PCO when there is an increased number of anovulatory cycle and consequently less progesterone to oppose the estrogenic effect. Okay, is it clear till now?
Yes, ma'am.
Yes, ma'am.
Yeah. Going for the PCO, if anyone can tell me about the PCO, what is the cutoff of the endometrial
7 millimeters. 7
millimeters.
7
Yeah.
millimeter.
7 millimeter. It is what? You
The
reassure
cutoff.
or you will reassure 7?
No, if it is more than 7, I will make a biopsy.
Yeah, if it is 7 or more, but if it is less than 7, you will reassure. Take care. Very important. Okay, this cutoff. If it is more the same, I mean, if it is equal or more, you will exclude endometrial pathology. But if it is less than 7 millimeter, you will go to reassurance. That's why I ask you. Okay, take care.
Okay.
Okay.
Yes.
For the estrogen producing for the estrogen producing, as we know, what is the most likely the tumor, the ovarian tumor. Yeah, it is as we know how much it's related to endometrial cancer, or the patient with endometrial cancer have granular cell tumor.
40%.
40%. Yeah, excellent. Okay, so have 10-fold increased risk of endometrial cancer. The progesterone, the risk of decrease when it at least 10 days of progesterone occur per 28 days. Okay. Yeah. For the family history, patient with this hereditary non-polyposis coli, known as the Lynch type 2 syndrome, have a 70% lifetime risk of developing colon cancer and 40 to 60% life risk of endometrial cancer. Very important. Okay, so 40 to 60% risk to develop endometrial cancer. Other this syndrome or the related cancer include the ovary, stomach, small intestine, hepatobiliary tract, upper urinary tract, brain, and skin cancer.
Well, for ovary, it is about 12% risk. For ovary, the Lynch gene is associated with 12% risk, lifetime risk.
Yeah, I think so. 12%, I think, the lifetime
Yes,
risk. Yeah.
Okay, okay, ma'am.
Okay. So what about the diagnostic technique used? The first thing is that you can use, for example, if you, most likely the patient, she came to you and she tells you that I have a vaginal bleeding, or you first thing you will go for transvaginal scan. Am I right? This is the first thing come to your mind. Okay. For example, if the patient came to you and she is postmenopausal, the cutoff to exclude pathology, what is it in the postmenopausal
4 millimeter.
4 millimeters.
4 millimeter. And if the patient was on tamoxifen or on HRT,
11 millimeter.
11. 8 mm.
Excellent.
8 mm for tamoxifen.
Tamoxifen 8, yeah.
Tamoxifen with asymptomatic bleeding, it is 5
tamoxifen
mm.
and HRT is 8. But if the
Asymptomatic,
patient,
it is 8 mm.
yeah. Okay. This is very important in the exam. You should know this. Okay. So
Rasha, 8 or 11? 8 or 11?
My dear. If the patient postmenopausal with tamoxifen or HRT, it is 8 the cutoff.
Okay.
Clear,
Yes.
clear written. Okay, clear written is the top.
I'm with 8, but I heard someone to say 11, yani, so I confused.
No. It is like this. And if, for example, it is 8, and the patient, most likely, you exclude, for example, any problem or any complex hyperplasia or whatever. If the patient refuse to take, for example, cyclical progesterone, and she refuse, I mean, the Mirena. Okay, the withdrawal, for example, to be induced, yani, if the PCO, yani 10, because some of you said 10. The 10, it is not for the postmenopausal. The 10 is for the PCO patient. If the patient is PCO, okay, and for example, you tell, for example, she had endometrial hyperplasia, and she refused, and you exclude, for example, any endometrial pathology, and then she refused, for example, to be given any cyclical progesterone. Okay. So the upper limit to induce withdrawal, if she refused cyclical progesterone, is that 10.
10.
Okay.
Yes, doctor.
Yeah, this is very important also. So for the diagnostic technique is that transvaginal scan, outpatient endometrial biopsy, for example, outpatient hysteroscopy, dilatation and curettage, and it is not recommended the DNC, of course, nowadays. For the DBS, the endometrial thickness of the postmenopausal woman is much thinner than in the premenopausal, as we know, and therefore more reliable, and it is used for predicting the presence of endometrial cancer. In the presence of the postmenopausal bleeding, a thin endometrium could be reassuring, and the patient wouldn't be require further investigation unless she continued to be symptomatic. Okay. The measurement is performed by measuring the thickness of both endometrial surfaces, and usually the endometrial thickness cutoff is 5, but this is not reliable for women with HRT who are premenopausal. Furthermore, in women taking cyclical HRT, the thickness could change depending on where in the cycle the measurement is taken. The pupil, as we know, is the most frequently evaluated device, and it is usually widely used. It is a fine bore plastic instrument This is just to know it. يعني. I will go through it يعني quickly. With a cuvette-like tip and a central plug that create a vacuum. It can be inserted either with or without local anesthesia, and once the plunger is pulled back, it is sucked a sample of the endometrium into the instrument, and the instrument is then rotated and removed slowly while keeping the plunger pulled back. It is then inserted into the formalin and the plunger replaced. Okay. This is the endometrial hyperplasia, as we know from the strategy, the type of hyperplasia and the malignant potential. You should know that the symbol is 1 to 5%, the complex is 25%, and the atypical is 50 to 75%. That's the previous classification. Okay, as we know nowadays, they just classify the endometrial hyperplasia into what? Anyone can tell me? Hello?
Without atypia and with atypia.
Yeah. So the risk of the the risk of hyperplasia to progress to endometrial cancer, how much? The new guideline, I mean, the GTG.
Without atypia, it is less than 5% over 20 years. And with atypia, it is about 25 to 30%.
And what about the complex hyperplasia?
With atypia, it's 25%.
It's 3%, and the symbol is 1%, as per the top. Okay, but here the previous one, this is the malignant potential and the type of the hyperplasia. This is from the strategy, and here for the type of the hyperplasia and the regression and progression. For the untreated simple and complex, the regression is 90% and progression is 1 to 5%. And for the atypical hyperplasia, is 60% regression and 25% progression rate. Okay, just if it came to you, because this is a strategy. For the type 1 and type 2, we have 80 to 90% of endometrial cancer for type 1, which is endometrioid adenocarcinoma most likely. And it is most likely the woman will be perimenopausal or early postmenopausal. For type 2, it is 10 to 20% uterine serous papillary or clear cell carcinoma, and it will be most likely for elderly women. Okay? For the low grade and high grade, the low grade, it is estrogen dependent, and for the high grade is no estrogen dependent. This is the low grade is with good prognosis, and the high grade is with poor prognosis. And the etiology of type 2 tumor may not be completely estrogen independent as previously believed. Okay? This is just the types. This is adenocarcinoma, and as we know, it is arise more commonly from the fundus. Several cell types can be distinguished as either mixed or pure. 75 to 70% endometrioid adenocarcinoma can be difficult to distinguish between well-differentiated and atypical hyperplasia on biopsy. 25% of the atypia have coexisting carcinoma. You should know this. If you have atypia, 25%, it's most likely to be carcinoma. And adenoacanthoma. This is if the focus of the intraglandular squamous metaplasia with adenocarcinoma. I know this will not enter your mind now, your brain now. Just I will go through it quickly. Okay. This is for the secretory carcinoma, which is a variant of adenocarcinoma in which epithelial cells are tall and pale with clear secreting cytoplasm, which is pure secretory carcinoma, are less aggressive and seldom myometrial invasion. Just in this slide, you should know that the adenocarcinoma is the most common, which is the endometrioid adenocarcinoma. It is 75 to 70%, and that 25% of atypia have coexisting cancer. Okay. This is the uterine papillary serous. It is and clear cell. It is papillary serous 5 to 10%, and clear it's 4%. From all the, this is actually the exam question. The clear cell cancer, it is 4% from all the endometrial cancer, and the papillary type serous carcinoma, it is 5 to 10%. Okay. It is similar to type in the ovary and fallopian tube. It is papillary and somoma body. This is most likely the thing which is distinguished from other type. aggressive and worse prognosis. If it asks you about the aggressive and worse prognosis, it is the papillary serous and clear cell carcinoma. Okay? Both invade deeply by lymphovascular space invasion and spread similar fashion to ovarian cancer. The full staging need laparotomy, as we said, that it is surgical staging, and omentectomy is required, and 50% treatment failure. Okay, the case management, it will include frequently normal inspection of the vulva. Suburethral area is common for metastatic deposit. You should take to see it. Exclude other cause for vaginal bleeding, and by manual rectal and vaginal examination to assess pouch of Douglas. An ovarian mass, for example, may be noted in case of the CA cervix, or CA ovary, or granulosa cell tumor. Okay. The preoperative investigation is that you full blood count, the glucose level, because it is included with the risk factor of it is the diabetes, liver and renal function, cystoscopy, and or plus or minus sigmoidoscopy if bladder and rectal is involved. In suspected advanced disease, ultrasound survey and CT scan should be done. Okay, staging assessment. The staging, the X-ray, the chest X-ray is essential, and the MRI appears to be the optimum method for assessing the degree, okay, for the myometrial invasion and the stage of the disease, and particularly cervical involvement as well as the pelvic and para-aortic, okay, and the presence of the occult cervical involvement. This is the most important. Most likely the MRI for the local IVC, and the TVS is an alternative test and may be useful for evaluating the degree of the myometrial invasion, but it is less accurate than MRI. The MRI is the top. CT is less helpful than a transvaginal scan. So MRI and then TVS to see the degree of invasion of the myometrium, and then CT is the less helpful. About the PET, CT has been identified as useful technique for detecting distant disease, which would be missed on routine CT. The evidence in the routine staging may not be fully evaluated. This is the staging. Anyone want to talk about the staging? Yeah, please.
Stage 1 is confined to the uterus. In stage, again divided into 1A and 1B. 1A if there is no myometrial invasion, or if it is less than 50% of the myometrial invasion. And 1B is invasion equal to or more than 50% of the myometrium. Stage 2 is where it has gone beyond its origin and it has invaded the cervical stroma, but it does not extend beyond the uterus. So in stage 3, it is local or regional spread of the tumor. 3A is tumor invades the serosa of the uterus and or the adnexate. And stage 3B is vaginal involvement and or the parametrial involvement. And in stage 3, it is metastasis to the pelvic and or the para-aortic lymph nodes. C1 and C2 is again divided. C1 is positive pelvic nodes and C2 is positive para-aortic nodes with or without pelvic lymph nodes. And stage 4 is tumor invades the bladder and or the bowel mucosa and or the distant metastasis. 4A is tumor invasion of the bladder and bowel, and stage 4 is distant metastasis including the intra-abdominal metastasis and or the inguinal nodes. So stage 1 is confined to the uterus, stage 2 is local spread, and stage 3 stage 2 is cervix, stage 3 is local spread, and stage 4 is distant spread now.
Yeah, exactly. Okay, just here, just to help you for the revision. Okay, the carcinoma of the endometrium, as we said here, it is confined to the uterus. It is just for the uterus. The first 1A is no or less than half of the endometrium. Okay, stage B here, 1B, this one, it is equal or more than the half. This one, 1B. Okay. It is for stage 2, it is tumor invades the cervical stroma here and or more than but doesn't extend beyond the uterus. Mean that just fills the cervical stroma, but not beyond the uterus. Okay, this is for 2. For stage 3, local or regional spread of the tumor. As we know, for stage 3A, you will the tumor invades the serosa of the corpus uteri. Okay, the serosa of the corpus uteri and or the adnexa, as we see here. Okay, for the stage 3B, what it is vaginal involvement, as we see here. Go for the vagina, plus or minus parametrial invasion. Okay, is it clear till now?
Yes, ma'am.
Yeah.
Yes, ma'am.
For stage 3C, metastasis to the pelvic and para-aortic lymph node. Okay, plus or minus para-aortic lymph node. 3C, it is metastasis to the positive pelvic and here to the para-aortic. Okay, here's the pelvis and here's the para-aortic for 3C. For stage 4, it is invade the bladder, go to the bladder and invade or the bowel mucosa, okay, and or the bowel mucosa. So this for stage 4A means that either the bladder or the bowel. But for the stage 4B, it will be distant metastasis involves the intra-even abdominal structure or metastasis for the liver, for the or inguinal lymph node. يعني خلاص, it will be spread. Okay.
Okay, ma'am.
Yeah. Just it is more, I think, 4 slides remaining. Okay, for the lymphadenectomy is a staging procedure to determine the need for adjuvant radiotherapy. In the UK, lymphadenectomy is not routinely performed because most patients are treated by generalists, and many patients are unfit or obese, which limits extensive surgery. Okay, so lymphadenectomy is a staging procedure. Okay, the multinational randomized control ASTIC trial, this is published in 2000, I think, didn't show any therapeutic benefit for routine lymphadenectomy in early stage endometrial cancer. Okay, and it is not, it doesn't improve recurrence. This is the ASTIC trial. If he ask you in the exam about the ASTIC trial, because it's written in the strategy, it didn't show any therapeutic benefit for routine lymphadenectomy in early stage endometrial cancer, and it doesn't improve recurrence. Okay, this is for the classification as grade 1, 2, 3, low risk, and intermediate risk, and this is for the stage with the grading I need. Okay, and here this is the mode spread, direct spread through the fallopian tube into the ovaries. Most common route is myometrial and eventually serosal, lymphatic to parametrial, vaginal, pelvic, and para-aortic. And for hematogenous, it is to the liver, lung, CNS, and bone is rare. Late stage disease. Okay. The treatment now. The treatment. Just put in your mind is that for treatment for stage 1 endometrial cancer is complete surgical staging, including laparotomy or laparoscopy with peritoneal lavage for cytology. Okay, this is lab trial, no difference between laparoscopy or laparotomy. So laparotomy or laparoscopy with peritoneal lavage for cytology. Also, you will inspect the area carefully and or palpation of the abdomen and pelvis, means the diaphragm, liver, omentum, and pelvis, and para-aortic lymph node, pelvic and bowel peritoneal surfaces, if there is any metastasis. Okay, so this is for, as we said, it is surgical staging. You need to palpate. Okay, so you need to do laparotomy or laparoscopy, peritoneal lavage for cytology, careful inspection and palpation for the area, for the organ. Okay, this should be followed by, so this is the first thing. Then you will go for total abdominal or laparoscopic hysterectomy and bilateral salpingo-oophorectomy. This for stage 1. Okay, is it clear till now?
Yes, ma'am.
Yeah. For the Portic trial, this is also trial. It states that no rule for external beam for early stage, means that radiotherapy. Okay. So the Portic trial, what she said no role for external beam for early stage. The treatment for stage 2, it includes the risk of the nodal disease is 14 to 30%, and some consider that it is mandatory to perform lymphadenectomy. Okay, so the treatment of stage 2 is radical hysterectomy plus bilateral salpingo-oophorectomy plus radiotherapy plus or minus lymphadenectomy. Okay, if it's trauma involved, okay, if it's trauma involved, you will go for stage 3, and it will be total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus adjuvant pelvic radiation. And here also there is a role for the Vortex trial 2. There is a benefit from brachytherapy, internal beam radiation in stage 3 treatment. Okay, and it will be like this: the summary of the adjuvant treatment in endometrial cancer in stage 1 endometrial cancer. If it is low risk, no further treatment. If it is intermediate risk, we will go for vaginal bolt brachytherapy. If it is high risk, you will go for external beam radiation plus vaginal bolt brachytherapy. Okay, so this most likely it will not be complicated like this. So just know that for stage 3 treatment is that total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus adjuvant pelvic radiation. Okay, because for stage 2 it is plus or minus radiation, but it is for lymphadenectomy. Am I right?
Ma'am, what is this low risk, intermediate risk, and high risk? How is it classified as low, intermediate, and high?
Before we said this in the table. If you go before in the table, this is the grade, and here we said that's the low risk. And just 1 minute. Just 1 minute. This one. You see here the low risk and the high risk. The high grade and low grade means that the high risk or low risk. Okay, the low risk
there was
is that
intermediate also, no? Low, intermediate, low, intermediate, and high was there in the chart, so I didn't get that part.
I didn't get you. What you say? Sorry.
There is intermediate also, no? In that chemotherapy chart, adjuvant for grade 1, it is given low, intermediate, and high risk.
Yeah, high risk most likely. The high and low, it will be low, the estrogen dependent and good prognosis. For the high risk, it will be poor prognosis and not estrogen dependent. Okay. Just let me to see what is intermediate.
Intermediate is it depends actually. This all depends upon the staging and lymphovascular space invasion. When we say about that low grade stage 1A, like grade 1 is low grade, no? Low grade with no lymphovascular space invasion, that will be low risk.
Yeah, we are aware of G1, G2, and G3 actually.
Yeah,
for the grade,
that grading is there. So it depends upon the lymphovascular space, stage, and grade. Accordingly, it is graded as low grade, intermediate, and high risk. Then
and
accordingly, if it is low, no need of any adjuvant treatment.
Yeah, and all of them are
so
included.
Low risk is G1.
Cancer. Okay, all of them are included in stage 1 endometrial cancer. Okay.
So low risk is G1 and intermediate risk is G2 and high risk is G3. Is it like that?
No, it is not
Actually,
like
what the
that.
thing is, there are 3-4
It
criteria.
is not
One
like that.
criteria
It is a very complicated this thing. It is given in this. You can just find it from
NCCN.
But in the traffic, if you want to read it, because no time now.
But it is very complicated.
Yeah, it is written in the strategy. Most, yani, it is with all things explanation, but don't go deep. Okay, if he tell you in the question that it is low risk, you know first treatment you will go for adjuvant treatment. But if it is intermediate risk, you will go for vaginal bolt brachytherapy. Higher risk, it will be you will go for this one, the external beam radiation plus vaginal bolt brachytherapy. Okay, just it is like this for stage 1. Okay, for stage 3, the surgery should include total abdominal hysterectomy plus bilateral bilateral salpingo-oophorectomy, and aim. Who asking about from where to read? From the strategy, okay? And aim to bulk disease, so adjuvant pelvic irradiation should be employed. This is for stage 3, okay? For stage 4, rare treatment should be individualized to achieve local control. Pulmonary metastases are the most common site of distant metastasis or distant disease. A combination of surgery and radiotherapy for palliative, local control, and chemotherapy for distant control can be used. And the progesterone have been demonstrated to be useful for pulmonary metastasis.
Please, Doctora, if there is difference between strategy and the green top for this one, which one we follow, strategy or the other? Because sometimes the strategy يعني old شوية.
Yes, that's why I bring from the FIGO. I take from FIGO and from the strategy. Okay, because the new one is the FIGO.
Yes.
Yeah, you will go for the FIGO, because even the strategy sometimes the trials and the researches, it is not RCOG.
Yes.
Yeah.
Thank you.
Okay. So treatment of recurrence. If no previous radiotherapy treatment, then the pelvic radiotherapy is appropriate. As the same, if you go for surgery, you will go for the opposite, and like this. If no previous radiotherapy, then pelvic radiotherapy is appropriate. Prior radiation with isolated central pelvic recurrence with no evidence of lymph node, as we said before, for recurrence, if it is central and no lymph node involvement, and it is less than 2, you will go for, no distant metastasis, you will go for central pelvic excentration. Okay? Excentrative surgery. Progesterone and tamoxifen have been demonstrated to produce clinical response in 20% of patients with recurrent disease. This is also from the strategy. Okay?
Yes.
Yeah. This is as per the cancer center, UK. It is for the stage 1, it is 85% most likely. For stage 2, it is 75%. And for stage 3, it is 45% most likely. Okay? The average. And for stage 4, it is 25%. Okay? This is for the 5-year survival. Okay? So 58, 57, 58, 85, 75, 45, and 25. Okay? Just I think just 3 questions. Just who will go with this? Finish?
I will try. I can try.
Yeah, don't be upset. And this thing goes, I will post for you, as I told you. I have 3 papers for both, for 3 the 3 cancers, the ovarian, and for the endometrial, and for the cervical cancer. I write it. I will post it. Okay, just 3 papers. Just go it before the exam.
Before September exam, please.
Yeah, of course, inshallah. Today or tomorrow, inshallah, I will post it. Okay.
Where will it be posted?
In my group. Okay. Who will go for this question? Let's finish.
Yeah, we'll go.
I'll do it.
Yeah.
You are Karina. Okay, sorry. Go
I
ask.
hope it will help you. Really, I know it is a very limited time, and really, oncology is not an easy thing. But I try to at least, to summarize it. It is in strategy very big topic, but I tried just to catch it, concentrate it. But really, it is not an easy thing. But just for the oncology, how to read it, just go for the staging and the treatment and the 5-year survival rate. Okay, that's enough.
You are carrying out a service improvement project within the postmenopausal bleeding clinic setting. You need to have an idea approximately how many new cases of cancer will be identified among the population of women being referred to the clinic. Which of the following represents the percentage of women with postmenopausal bleeding who will found to have an endometrial cancer? It is 10%.
10%, exactly. Excellent.
A 51-year-old woman presents with a 2-month history of postmenopausal bleeding. Her period stopped last year and she has been using continuous combined hormone replacement therapy for 9 months. A transvaginal ultrasound revealed a normal-sized uterus with a normal ovaries and an endometrial thickness of 3 mm. Clinical examination was unremarkable. What is the most appropriate management? So she's on continuous therapy. Her this endometrial thickness is just 3 mm only. So management will be cervical change to the cyclical hormone replacement therapy without performing further investigation, endometrial biopsy, inpatient hysteroscopy to cease hormonal therapy and investigate further to cease hormonal therapy and investigate further if symptoms persist.
If symptoms persist beyond 6 weeks, okay? This was the answer. Okay, so to cease hormone replacement therapy and investigate further if symptoms persist beyond six weeks. The correct answer is to cease hormone replacement therapy and investigate further if symptoms persist beyond 6 weeks. And the continuous combined HRT preparation are not suitable for use in perimenopause or within 12 months of the last menstrual period. Women who use such preparation are likely to suffer irregular bleeding and should consider changing to cyclical HRT. Okay, in this, if following cessation of HRT, bleeding persists beyond 6 weeks, further endometrial assessment should be done. Otherwise, assuming the bleeding stops and the preparation could be changed to cyclical preparation.
A 60-year-old postmenopausal woman who is using tamoxifen for breast cancer presents with a history of postmenopausal bleeding. Transvaginal ultrasound shows an endometrial thickness of 5 mm. What is the best course of action? So it will be outpatient hysteroscopy with biopsy. B.
Okay. Okay.
Not Bill Ferris. Not Bill Ferris here.
No, this patient is a high-risk patient, no? So outpatient hysteroscopy.
Yes, hello? Yes?
Yeah, yes.
Yeah. So this paper actually, I did it before when I was in the exam. So just I put it for you just to remind you about the chemotherapy and which one with caution with patient with diabetes mellitus and which one with require, for example, hydration pre and post. This is very important actually. It is I think EMQ. It's very important to make sure of it, okay? Because myelosuppression came the bleomycin, one of the recall question. The chemotherapy not associated with myelosuppression, which is bleomycin, okay? And for the one with, I think the bleomycin with pulmonary problem, am I right? The bleomycin. Yeah.
Yes,
So yeah, you should
fibrosis.
know this. Yeah. And
Yes.
about the doxorubicin, about the risk of cardiac failure. Just I am catching the things, okay, for you to remind you, okay? And for the chemotherapy given IV and oral, it is eptospicide. And for the chemotherapy associated with hand-foot syndrome and exacerbate angina in patients with ischemic heart disease, which is fluorouracil. And the chemotherapy which use serum creatinine, it is carboplatin, it is CC, carbo and creatinine. Okay, risk of infertility increase with alkylating agent or the platinum drugs, and the hair loss is caused by anthracycline, taxane, alkylating agent, and etoposide. Okay.
Okay.
The last question.
A 66-year-old woman presents to the GP with 2 weeks of bleeding. Her last period was at the age of 54. Past medical history includes chronic hypertension treated with atenolol. She had one child at the age of 28 and is obese with a BMI of 32. She had a 2-week referral for gynae outpatient where she had a papillary biopsy. The results of the later ultrasound and the scan confirm endometrial carcinoma confined to the endometrium with less than half of the myometrium involved. She is understandably devastated but very keen to discuss the management with you. So she has stage 1A endometrial carcinoma. She can go, she is a postmenopausal lady. She will go for the total abdominal hysterectomy plus bilateral salpingo-oophorectomy.
So the answer is
B.
less than half of them, and but very keen to discuss management with you. 2 weeks of bleeding, her last period at the age of 54. This patient, what you will do for her?
Let us see option.
Easiest operation is to do simple hysterectomy.
Unsuitable. The question is asking about the
total
unsuitable.
laparoscopic hysterectomy and bilateral salpingo-oophorectomy.
The unsuitable for her, what is it?
Okay, unsuitable. Unsuitable is
radiotherapy.
Excellent, exactly. So that is why I put this question to, yani really very important to read the question carefully. Okay, very important to read the question carefully because it's the thing which is unsuitable for her. Okay. Just these are the last things. I have just 2 points I want just to tell you about it. The first thing is that when you go for to solve the EMQ, okay, and the first thing is that you should read the scenario well as now, and also know what he wants from you. Okay, exactly. Then underline the important point as no time to write it. Okay, so if you read the imagine that you are now in the exam and now you have the question on the EMQ, read the scenario and just make a line on the thing which is the key point, okay, because no time to read it again, and put the answer in your mind, then search for it for answer, because you may find a suitable option, a better one, more concise one. Okay, this is very important. And in the exam, start with the EMQ. It is 3 hours. Go with 2 hours for the EMQ, and it is 1 hour. It is very enough for the SBA. Okay. I know all of you now are feel that you are stressed and exam will just few days, but no doubt that prayer and these things, it will help you a lot. And also just wait the answer from Allah. Inshallah, just do your best and Allah will be with you. Okay. And what I want to ask you also, tell you, anything you read it, revise it. But don't, for example, go a lot, all the day till night to read. No, just it is for 11. It is enough. 10, 11 p.m. enough for you. Don't go beyond that. Okay, and it is better to go early. You go your prayer and go early and revise the things which is these days. Actually, the most important thing is that the oncology, the staging, about the statistic, also important to be revised in these 3 days, very important. And also even in the day morning, in the day of the exam morning, very important. Okay. And for the because there is 4 things, it is no exam without it. For the oncology, for the infertility, for the urogyne, also it come. So just take the thing which is like 50% it will be there, or maybe 70% will be there. Okay, oncology, infertility, statistic, and these things, very important. Okay, try to make an exercise every day. For example, go walk, very important for you. And as I told you, sleep well, and don't panic yourself even in the exam. Don't talk after, don't talk before the exam, or just go for the area of the exam and keep don't panic. Okay. And I know these days is very critical for you, so try to revise the things which is you didn't get, you didn't revise it late. Go for the everything that you revised it before for a long time. Okay, I hope inshallah our crash course this year was helpful for all of you, inshallah. If you have any question, don't hesitate, ask me in my Telegram group or even in my private Telegram. Okay, and I hope all of you inshallah will pass this exam and go beyond inshallah and succeed in this exam inshallah, all of you. Okay.
Thank you, ma'am. Thank you so much.
Yeah,
Thank you. Thanks a lot.
Yeah,
Thank you,
and
ma'am.
thank you all of you. Thank you very much indeed.
Thank you so much, Dr. Rasha. We'll be expecting the posting of the PDF and videos, please.
Yeah, inshallah, of course, inshallah.
Thank you, ma'am.
Inshallah,
All right,
but just sometimes I know that it's critical time, but believe me, because I'm working in the very busy hospital, really, and I'm trying myself to finish and finalize these things, because preparing for these things, it is not an easy. You need time and you have others issue, your family, your work, a lot of things. But I hope it is this crash course, this time help all of you inshallah, and all of you I want just text me. I want your names in the first of the list inshallah, all of you inshallah, all of you.
Inshallah.
Okay. Yeah, and just I want to tell you is that after the exam by 2 days we will do go to meeting. Okay, for the one who attend the exam, please be with me, because we will do the same as we did in the February 2020 questions. Okay, so please all of you who attend, please inshallah after 2 days, because I want to give you 1 day for rest, 1 day for travel, and the third day just to tell us about the questions. Okay, hope the success for all of you inshallah.
Amen.
Thank you, ma'am.
Thank you so much.
Thank you, Dr. Rasha.